Thank you so much. So now, we originally had 3 talks in the first session. This is the ICP Program 1, which will be followed by ICP Program 2. Dr. Bokhanto Hazarika's talk was already rescheduled. It was delivered 2 days ago. So for the first session, we have 2 talks. To chair the session, I would like to invite on stage Dr. Madhav Mishra, Dr. Ajit Pegu, Dr. Amaldev Goswami, Dr. B.C. Kolita, Dr. Manoranjan Malakar, and Dr. Rasmita Upadhyay.
Hello. Okay. Very good morning. After 2 successful days of program, today is the 3rd day. I hope we will score the century today also. And today's, actually it is a ICP program, the module program 1. And we have a very interesting topic, and we have very renowned speaker of the repute in our country, Dr. Jyotirmoy Pal, Dr. Tibeni Sharma. The first speaker of today's morning session will be delivered by Dr. Tibeni Sharma. She will be talking about nutritional issue in elderly bedridden patient. Can I have her first slide? First slide. Dr. Tibeni Sharma is the professor of medicine, Guwahati Medical College. She is very active in API activities throughout the state and country also. And without any delay, I request Dr. Tibeni Sharma to kindly deliver her lecture.
Good morning, respected August gathering chairpersons. So today's talk will be mainly on the nutritional issues on the elderly bedridden patients. So aging is characterized by diminished organ system reserve and weakened homeostatic control. And because of this, the risk of malnutrition is much more in the elderly population. So in this study was done in Chandigarh, PGI. It was a systemic review and meta-analysis of 45 studies all over the country. And it was conducted mainly in the old age homes and in the rural areas. So they have found that the malnutrition is much prevalent in our country. Central India has the greatest number, and even in the northeast. So even in northeast, the number is not less. It is above 50%. And the idea was that, for the community medicine, as they have programs for the children and the adolescents, so programs can also be started in the elderly population for malnutrition. Now, whenever a person is bedridden, so the first thing is that we have to know whether the person has malnutrition. So we have this diagnostic criteria from different groups. One is the European Society of Clinical Nutrition and Metabolism, which gives importance on unintentional weight loss of more than 10 to 5% together with a decreased BMI. And we have the ESPEN criteria also, Academy of Nutrition and Dietetics Academy. American Society for Parenteral and Enteral Nutrition. They have 6 characteristics, and 2 out of these 6 characteristics, if it is present, it suggests malnutrition. And we have the GLIM criteria also, which has if one phenotype or one etiologic criteria is present, it is considered to be malnutrition. And for screening, the next thing is that these bedridden patients, they have to go through certain screening, and we have a lot of tools for that. We have the malnutrition screening tool, we have the and malnutrition universal screening tool. We have the short nutritional assessment questionnaire, and these tools, like, they have different scores. They are just very easy actually. They are just questionnaires. So we can take help of these questionnaires and these tools, and according to the scores, we can diagnose malnutrition in the elderly population. So these are the different questionnaires. Just we can find these questionnaires and then we can take out the score and find out who is suffering from malnutrition. The next thing is that it will be good if we remember the common 9 Ds. These are the dysphagia. A post-stroke patient with a neurological deficit can complain of dysphagia, diarrhea, dementia, dentition problems, and dysgeusia, that is a loss of the pleasure to eating because of loss of taste buds. And even drugs also, these elderly people, they are on polypharmacy, so the drugs also, like there's loss of appetite and there can be interactions, and so they are more prone for. So it's good that we remember the 9 Ds when we are dealing with these bedridden patients. And it is seen that, the psychological stress and depression is very common in the elderly, and they have to be, and this has to be taken care of very seriously in the elderly population and managed. And this is just mnemonics about the 9 Ds. So a mnemonic is there. This is a Meals on Wheels mnemonic. So just to remember the 9 Ds, it is this mnemonic is there. Then the next is the algorithm. We can follow this algorithm. Like if there is a weight loss of more than 5%, we have to find out whether it is adequate calorie intake is there or not. So if the adequate calorie intake is there and the patient is eating properly, but still he is having malnutrition, then we can think of malabsorption. We have to rule out malabsorption. If there is malabsorption, we treat it. If there is no malabsorption, we have to think of underlying infections or malignancies, or heart diseases, heart failures. And suppose there is no access to nutrition, that is a social factors are there. And suppose there is access to nutrition, the patient is taking also orally, then we have to think, but still he's going towards malnutrition, then we have to think about the 9 Ds. Now, this is critical illness is always a state of catabolic stress, and the nutritional requirement is much more than in the normal elderly patient. Suppose a bedridden patient, he is on bed sores and he is in a state of infection, then his nutritional requirement, especially the protein requirement, is more than the normal standard person. Now this is how, this will tell us that what is the calorie, how much calorie this elderly person needs. So we have the indirect calorimeter, which is not very easy to be done everywhere. It is done through different equations, like the Weiss equation and the Harris-Benedict equation, which takes out the volume of oxygen consumed and the volume of carbon dioxide produced. But these are, it's a very complicated. So we can take a very simple weight-based equation. It is just 25 to 30 kilocalorie per kg per day. So this is very easy. 25 to 30 kilocalorie per kg per day. That is the energy requirement of a person. So again, this is another way of finding out the calorie requirement. It is based on the resting metabolic rate. So suppose I'm just giving an example. Suppose a person, an elderly bedridden person, he's 60 kg. So if we 25 to 30 kilocalorie per day means 1500 kilocalorie, which now 15 to 20% should be protein, as we all know, carbohydrates and fats. So that comes to be 300 for kilocalorie for protein, 800 for carbohydrates, 350 for fats. Now, if there is a bedridden person and he cannot, suppose it's a post-stroke case, he is on tube feeding, suppose enteral tube feeding. Now, what do we do in these cases? We usually take help of this oral nutrition supplement. We get it in packets and powdered things, like we all know, like those brands. We usually use those oral nutrition supplements. Now how to calculate from here? Now these tins or these packets, the 100 grams contain 430 kilocalorie. So the idea is that if we take 8 scoops, 8 scoops will contain 71 grams, and 71 grams has 350 kilocalorie. And in this 350 kilocalorie, we have 56 kilocalorie for protein, 72 for fat, and 160 for carbohydrates. Now the thing is that if we give 8 scoops at one time, and we want to make it 1500 kilocalorie for this 60 kg person, then we have to give 8 scoops almost 4 to 5 times a day. So that is quite a big amount. Like the one tin finishes off in 2 or 3 days. So like, but we are not following this. We just give we give 2 scoops or 3 scoops 8 hourly. But ideally, if we want to have the calorie requirement only through this ONS in a tube feeding person, we should give 8 scoops, that is 71 grams. We have to give it 4 to 5 times. And 1 scoop ideally should be mixed with 30 ml of water, because again, the way we calculate it, 25 to 30 kilocalorie per kg per day is the energy requirement, 30 ml per kg per day is the water requirement or fluid requirement. So these 8 scoops, we have to mix it up minimum with 200 ml of water. That is 1 scoop, say about 30 ml of water. So that is how we can plan the whole thing. So suppose we are not being able to do this 8 scoops 4 to 5 times a day. So what do we do next? We have to take help of this, kitchen feed. So just a brief thing about this kitchen feed is that a dietitian will know much better. And when we are dealing with these bedridden patients who are totally on enteral tube feeding, we have to take help of the qualified dietitian. So you see that the masoor dal, 1 cup is 100 grams. It is equivalent to that 71 grams of, that is 8 scoops of this ONS. So 8 scoops of ONS is 1 cup of masoor dal. And then, as I have said, that in the catabolic stress, like those people who are underlying infection or sepsis or with a bed sore, who needs more on the protein, then we can add, things like masoor dal, and then the kidney beans, the rajma, it's very good source of protein. Here 1 cup is 613 kilocalories, and out of that 44 grams is protein. And then fish and chicken, we all know about eggs. Eggs are the first class protein. So we can add this kitchen feed together with this ONS supplement. But our idea is that we have to make it that 25 to 30 kilocalorie per kg per day. We have to make it that 1500 or 1600 kilocalorie, whatever that person is requiring. And if he is in a position of in catabolic stress, then we have to increase the protein amount. So here, this is a study which has which gives us an idea that the protein requirement, the normal dietary protein requirement in an elderly person is 1.2 gram per kg per day. And since he have this elderly population, they suffer from sarcopenia and certain, mainly sarcopenia due to various factors. So what happens is that the current clinical recommendations are to give patients with mild to moderate illness 0.8 to 1.2 grams per kg protein per day. This slide is mainly dealing with the protein requirement. And in more critically ill patients, the requirement goes up to 1.2 to 1.5 gram per kg. And in this oral nutrition supplement, the protein given is mainly in the form of leucine. So dietary fibers is again so very important. We should never forget that dietary fibers should be included in the nutrition of these bedridden patients, because again, this is a study. This was also done with a meta-analysis and a systemic review of 8 studies. And it was seen that when dietary fibers was used in the diet, then it decreases the incidence of stroke, heart disease, colon cancer, hemorrhoids, easy way to control blood sugar. So dietary fibers again have to be included in the diet. So this is again an algorithm that how to go for this nutritional support. Now here the main thing is that whether the person has a functional GI tract or not. If the person has a functional GI tract, then the enteral nutrition is the best. Whether it is orally he can take is fine, otherwise it is the tube feeding. And if there is no functional GI tract is not that proper, then the person has to go for parenteral nutrition. Now, another thing that we have to remember is the refeeding syndrome. A person, like if he is, he has malnutrition, if he has not taken food properly for a significant number of days, say around 1 week, there was a starvation or there was a very less intake of food and the person is having malnutrition. Now, if we give him a feed, you know, suppose we give him whatever calorie requirement he requires and we give that requirement at in 1 day, like suppose we do that, then there is a chance of having refeeding syndrome. So it has to be, for those people, the nutrition has to be done in a stepwise fashion. Otherwise, this refeeding syndrome is quite a serious problem. There is electrolyte disturbance, there is hypophosphatemia, there'll be you know, when a person suddenly is given carbohydrates, there'll be insulin surge, there'll be fluid retention. So those patients who are like having these cardiological problems or a heart failure patient who are not having, because of some critical illness, not having food for quite a long time, we have to build his nutrition or we have to give his calorie requirement in a stepwise fashion. So enteral nutrition is always better than parenteral because there are mainly one thing is that the chances of infection is less. Parenteral nutrition has an increased chance of infection. And contraindications, we all know of enteral nutrition. There is intestinal obstruction, hemorrhage, ischemia, intestinal ischemia. And this is again an algorithm for the approach to the stroke patient. Now stroke patients, like a person who was in stroke and has gone home now and then he cannot eat, he has got dysphagia, he is on the tubal enteral feeding, then we'll have to think about, you know, we have to properly think about the calorie requirement that he needs. And if he has dysphagia, then though he will be on the tube feeding, but physiotherapy, and you know, there are many swallowing physiotherapy is also there, which you know, stimulates the swallowing reflexes and all. So those have to be done. The physiotherapy, we also have to take help of the physiotherapist. And this is again the third water requirement. This slide about the CKD patients. So the CKD patients, again the energy requirement in a non-dialysis CKD is 30 to 35. It's almost same with the hemodialysis and the peritoneal dialysis. But those patients who are undergoing hemodialysis or peritoneal dialysis, their protein requirement will be more than the non-dialyzed CKD patients. If the non-dialyzed CKD patient 0.6 to 0.8 gram per kg per day, but the person going through hemodialysis and peritoneal dialysis, it will be slightly more than 1.2 grams per kg per day. So this is basically a diet chart. I just got a diet. We will all get this diet chart for CKD patients. For the diabetic patients almost the same, but the carbohydrates and the fat quantity should be less.
Dr. Sharma, kindly summarize.
Okay. So this is so this is basically about the nutrition, and the take-home message is that for all the bedridden patients, we have to assess whether the person is having malnutrition through malnutrition screening tools and the criterias, and then we have to plan the amount of calorie he wants and whether we give it in enteral or parenteral basis, and if we are giving him an oral nutrition supplement, how to calculate the calorie. Thank you so much for your patient hearing.
Thank you very much. Now I hand over the mic to my co-chair.
So we will be taking up questions after the session.
Thank you
so much. May I now request our next speaker, Professor Jyotirmoy Pal. He doesn't need any introduction. He will be giving the Dean's keynote address. He'll be speaking on, are we missing the tender feeling Okay, sorry. Uh, Tender healing touch of physicians in this digital era. So this is again continuation with yesterday's our presidential address. Oration. So without delay, may I request Professor Pal to start his.
I don't know it. Thank you, organizers of API Assam chapter, for keeping this issue as a theme issue of 3 days annual conference. Usually in the conferences we see the theme is like this: medicine update, medicine advancement in the medicine of the new decade. But I can remember one poetry from Rabindranath Tagore, Dao Fireshe Aranyo Law e Nagor. So very nice, madam, you have chosen and you give an oration on the subject, that is empathy or tender touch. How much is it relevant? I can say this, what madam discussed yesterday or what I will discuss now. This is basically an introspection. What we are doing, whether we are in a right track or in some deviation. If it is right track, okay. If we have deviation, we should think. Nothing we want to impose as an organization, but we want to introduce some of the thoughts in your mind so that we can think and we can discover what should be the right pathway for our future. So, are we losing empathy in the era of digitalization? First, I will start one story. There is a Dharmabhag Upakhan from Mahabharata. You know the story. During the Bonavas Parva, the 4 brothers of Yudhishthir first went to a pond to take water. That one crane came and asked not to take water without replying to his questions. 4 brothers refused and they died. Finally, the Yudhishthir went there, and the crane was the Dharma. So he asked 18 questions. And one question was, who is the friend of one who is ill? Yudhishthir's reply, it is the physician who is the friend who is ill. So that means a good physician treats a disease, but the great physicians treat the patient, not the disease. But what we see, in the last 50 years, we see lot of litigations, lot of allegations, lot of criticism, Consumer Protection Act, doctors' assault, and we are habituated to all these things. So what happens in the last 2000 years, when the Mahabharata was written 2000 years back? So let us discuss. Ma Sharoda once told, if you are criticized by others, do not find fault with the others, rather learn to see your own faults. So from that background, we discuss historically. In the period of Vedas, the physician was worshipped as a god. The god Dhanvantari is the son of the Vishnu. So that means doctors was placed in the place of the god. Deviation started in the around 1000 before Christ. So Charaka and Sushruta and Hippocrates, they try to make some code of conducts for the doctors, because they then realize that now the physicians, the doctors is deviating from their pathways. Then the dark age of Europe started. At that period, doctors' role for treating disease become minimum. Doctors were mainly engaged of treating the royal peoples. Only common peoples were dependent on the religious churches, some natures, and superstition, this and that. The first change came during the French Revolution, because the new system of medicine developed and accurate diagnosis and the treatment on the scientific basis. This thought basically evolved after the French Revolutions. 19th century, yesterday madam told very nicely, the Richard Hutchison, basically he described and he advised not to treat patient as a substrate, but as a person. Royal College of Physicians they also declared that patient was not simply an object but a person. So 19th century, the different authorities, they set up a high moral for the doctors. But deterioration started from the 20th century. In the early 20th century, during the period of two World War, there was a rapid advancement of medical science, and empathy was partially taken away by the structured scientific approach of medicine. Patient was started considering as a substrate, and the deterioration further accelerated in the late 20th century. Here, patients are considered as a customer or client, and commercialization basically engulfed our medical professions. And rapid advancement, the physicians are now converted to more a technologist. And we see in this century insurance-based practice, evidence in the name of evidence-based practice, we are more dependent on the technology, some data, this and this, and see lot of litigation, Consumer Protection Act, physical assault, so and so. So what happens in last 100 or more than 100 years? Are we losing empathy? Are we becoming more dependent on the technology? Are we going away from the patients? What happens? This is the questions. So these questions we will describe, because now there is a two perception. One perception is we will consider the patient as an object, as a customer, client, not as a person. Or we will consider a patient as a person. So to get the answer, I will put some of my life experience to you. When I passed MD medicine in the year of 2000, not from West Bengal, from outside West Bengal, I came back to my locality and started practice. In the first few months, I can remember, every day I used to go to the chamber, no patient. First few months, I remember only one dog bite patient came. And I see, then one day I was thinking, I have a very bright academic career, I got the gold medal, MD, why no patient is coming? Whereas some of the doctors, only MBBS degree and doing some non-scientific prescription, putting only some vitamins in this and that, enzymes, and they have 100, 200 patients per day. What is the mystery? So I got the answer after few days. That time one day my son, around 3-4 months, become ill, suffering from a respiratory illness. That day, it was Sunday. I called few of the renowned pediatrician of the locality. That time I was totally unpopular or not very well known to the people of my locality and also to the doctors community. So I called one person, he is a MD, very senior. He told, today is Sunday, I do not see the patient. I requested, my son is very ill, suffering respiratory rate is more than 30. Said, please see. No, today is Sunday, come tomorrow. I called another doctor, he was associate professor in pediatrics. He told, my chamber, all appointments are full. Sorry, today is not possible. You talk with my secretary. So 3-4 people, doctors I called. Nobody replied. Sunday, I being very puzzled. Then my housemate, maid servant, they told, sir, you can consult Dr. Champeshwar Mishra. He is a doctor pediatrician, came from Odisha, only DCH degree. And usually the rickshaw pullers, maid servant, this type of population is their patient. Maid servant told, he is a very good doctor. Take only 30 rupees, even after that give some samples to us. So I taken the phone number from his prescription and called him. Before that, he was not known to me. I give my introduction, I am doctor this. Oh, so you come, immediately come. So Sunday I went to his house, he has seen and arranged admission of my son. My son recovered. After that, believe me, till my son not become adolescent, all vaccination, everything, in spite of having so many reputed doctors in my locality, I always consult Dr. Champeshwar Mishra. Then I realized what is the mystery, why some of the doctors having so much degree, not respected or not reputed in the locality, but some of the doctors without having degree, without having such glamour, some secretary in their chamber, but flooded with the patient. So that day I realized what should I do. From that day, remember, Even in the midnight, somebody come to me, my house, I never refuse anybody. My wife told, no, don't refuse any patient, anytime. Even in the midnight, if somebody calls, at least I give some reply. You do this, take paracetamol, this and this. Because that day I realized, in the odd hours, if somebody become ill, that time I was not doctors. I am a father of a son. What can be the psychology of a patient or patient relative? I was reading one article written by Dr. Devi Shetty. Shetty was telling, he was very popular. He is almost considered God in most of the part in Calcutta, definitely Assam also. I know Shetty. Shetty previously early life he was settled in Calcutta. So one day he has written, the one day phone call came that doctors you have to come to house call. So he was engaged in the operation. His secretary replied, he is a cardiac thoracic surgeon. What will going in home? But from that end, there was a repeated request. The Shetty accepted the request and went to her house. That day, that lady, old lady, told her, Dr. Shetty, I know you can give prescription over phone, but I need your tender touch. That lady was Mother Teresa. And she told, the hands that help are holier than the lips that pray. Shetty told, in my chamber, I have kept a photograph of Mother Teresa and her quotation. By profession she is none, but she still believes the tender touch is more important, and the hand by which you can help the people is more important than the pray what we are doing from his lip. So this is the message. The Swami Vivekananda told, that is why Jive Prem Daya Kore Jeijon, Seijon Seviche Ishwar. So that is why Ramakrishna Mission has a two wing, one mott, one mission. Mott is for the religious activity and mission is for the social activity. Because Swami Vivekananda thought, if we cannot give the food to the poor people, there is no word or no religious can survive without the food. Food is that is why you see in the Sikhs, they have the langar. Because Guruji told, to poor, it is not the message of our religious books. It is the food that is more important than what you are telling as a religious words. So this is the message. So you have to help the people. From that I learned, actually from that story, still I practice. If the patient suffers from gastroenteritis, I put stethoscope on his chest. Because that person do not understand, they putting stetho, what I am getting. But people have a concept that if the doctor put the stetho, then he can get the all information of my body. That is the common. I know putting the stetho in the gastroenteritis patient, I will get nothing from the chest. But people thinks that doctors is getting all information of my body, putting stetho in my chest, on my back. So if you allow, I can spend some extra time. So this is the message, because tender touch, why is more important than what technology or what modern medicine, what the evidence-based medicine you are applying. You see from your own experience, because sir is Director of Medical Education, you know sir definitely is a member of the Medical Council of the Assam also, by virtue of your post. You see all the litigations are coming against the super specialists. No litigation against the quack. People know he has no degree. Very little allegation against the general practitioner, MBBS doctors, but all the allegations against the specialist or super specialists. Why? Because you see the quack doctors or the general practitioner who practice in like a family physician, they go to the burning ghat, they go to the funeral ceremony, they go to the marriage ceremony. If they meet the people in the locality, they namaste, they say namaste, they do the handshake after Vijayadashami. So social mixing or mixing with the people is more with the quacks and general practitioner. But what we do, if the people call us, we do not pick up our phone. Our secretary pick up phone, give the time, you call tomorrow, you call in the afternoon, sir is busy, or my phone call is forwarded. That means our distance with the patients increasing and increasing. We do not respond the patient call. Simple a phone call, simple answer, you take some pantoprazole. That can be a healing touch to the patients. But if I say, no, no, this is not the time, you pay online or your fees, then I see your reports, I will discuss. So this can increase the distance, and this is increasing rampantly between the patients and doctor. That is why all the allegations is coming against the specialist and super specialist, not against the general practitioner. And even the quacks, people know he has no degree. But you see, if you see the rural people, they have a lot of respect about them. So that means what the judiciary has told, the physician is a friend. Now we are not becoming the friend, rather we are becoming the service provider. Service provider. That is why, so that means patient is a consumer and we are service provider. So I can say, so that is why a Consumer Protection Act is imposed on us, because we are responsible. We are becoming service provider. We are considering patient as our client, as our customer. So definitely consumer protection will be imposed on us. I can say you another very nice story. One day I went to one of my friend's house. That is called New Barakpur area near Calcutta. Then I asked about one doctor. I know he stayed in nearby. He's the DM endocrinology. I know you know him. That person, old person replied, yes, I know, he has some hiji-viji degree. Hiji-viji Bengali means non-specific degree. He has a MD, DM, he was a professor of endocrinology from a very reputed medical college in the city. Then he told, one day my uncle expired. I called him. He told, I am an endocrinologist. I cannot give the death certificate. He refused. But then he continued. His father was a genuine doctor. When my grandfather suffered from diarrhea, we called him whole night, wearing a lungi. He treated my grandfather, giving saline whole night. No, how good doctor was. So this is the perception of the people about the doctors. You may have so many degrees, but if you are not friendly, if the person died, if you don't show sympathy, if you don't give the simple death certificate, people will not consider you as your man. He will consider you as a technocrat. He will give the fees, he will take the suggestion. Not your man, your friend, your relative, but the person who whole night wearing a lungi will serve you. People will think he is a friend, he is a philosopher, he is a guide to you. That is the difference. That is the concept of perception of a doctor can be vary from your act is responsible for this changing perception in the locality. Regarding the technology, definitely we have a advancement of the technology, but many of us, when particularly we sit in the corporate hospital, we do not, lot of patients, we do not give much time about the patient's psychology, their economic issue, their caregiver, only based of evidence-based medicine. We think these are the medicines. These are the anti-diabetic medicine will be best suitable for him or her. But we do not consider whether patient can purchase, whether we can give some insulin, but we do not consider whether patient has some caregiver, whether patient vision is all right, whether patient has dementia. We do not consider all these things. We just, on the basis of evidence on medicine, on the basis of science, we advise some medicine. And compliance become very, very poor. So that means too much dependent on the evidence-based medicine. Without empathy, we are not doing good for the patient. We are not treating the patient. We are treating the disease only. So you have to treat the patient, not the disease. So my advice, what we are discussing, these are basically all the introspection. So do not take to your heart, because you think yourself what we are doing, is it right or wrong. If something is wrong, definitely we change. I know many of the doctors.
Excuse me, sir, I think we are, so
2 minutes.
like to,
2 minutes. So we know few of the doctors give round at the midnight. So this is not the example of the good empathy, because midnight is the time the patient for sleep. So my advice is We need a introspection, definitely, whether we are in the pathway that was set up by the late Dr. B.C. Rai, Nilratan Sarkar, Jibraj Mehta, or we are engulfed by the poison of commercialization. If we are engulfed, we have to come out from the pathway. So I will end with the small clippings, because in most of the movie, doctors are depicted as a villain. See, I think seniors can recognize the movie.
और वो चाहे जिंदगी बड़ी होनी चाहिए, लंबी नहीं.
So Dr. Bhaskar replied, आपको हंसना, आपको खुशी रहना, ये मेरी सबसे बड़ा इलाज है. Next, if you cannot recognize the movie, now we can recognize.
Thank you, sir, for a well elaborated. So, as the proverb goes, touching is healing. So, in this era of digitalization, I think we are forgetting the tender touch. And I can share an experience of mine. Once a patient of mine went to Apollo Hyderabad, and actually he was referred to the main doctor. After coming back, the patient told me that who saw me, I didn't see the face of that doctor. They showed me the prescription of him. So as soon as he entered the hospital, there were a lot of tests and all. As he was passed through many tests, and many doctors have examined him, but ultimately to whom the patient went to meet, he couldn't meet. So that is the era, I mean, in this era of digitalization, we are really becoming more and more harsh to the patient. That's why I think we see a lot of these incidents against doctors. So first and foremost, which we were taught in our medical schools, the oath we took, I think we are forgetting those principles. So in this August gathering, as a chairperson in this August podium, I am very grateful to the organizers who has given me the chance to chair this, and that to ICP Dean Professor Jyotirmoy Pal, who is known to everyone. So we should not forget, actually touching is healing. As soon as you touch or speak to a patient with a smiling face, half of the disease is cured. So I think it's a very wonderful speech you gave, sir. And with this, I would like to, the topic is open for discussion.
It's a very beautiful talk. Sir has already told touching is healing. At least we should touch our patient. Just only seeing the reports, and in corporate hospital, normally we see everything was done outside. Patient will go, the history reports all done, the doctor will only prescribe. The patient used to come and tell us, ma'am, he didn't touch us. They want to feel that touch. Sir has already told that in gastroenteritis patient, we didn't get anything from putting a stethoscope, but still we get something. So the topic is open for discussion. We can entertain one or two questions. Dr. Triveni Vaidya has given talk on nutrition in bedridden patients, so we can have some questions. Dr. Triveni Vaidya, you can come over to the stage also.
I have a question for Triveni ma'am.
Actually, after hearing your lecture, several things are coming to my mind. Previously, the doctors were such, they were approachable at any time. What you said at midnight, because yesterday I told you that my father was a physician, and at that time there was no mobile. There was only the landline. So he never kept many doctors were there that switched off the landline at night. But even if it is at midnight, he will get up and he will take the phone and he will answer. So the doctor has to be accessible. and then only the doctor, the patient feels comfortable with the doctor. And I am speaking about my father. He was an Assamese doctor, but he used to speak Bengali very well because obviously he was an alumnus of Calcutta Medical College. He used to speak Nepali very well. He used to speak Oriya. So all the people, they think that he is their doctor. So that is a way that a person, a doctor, actually can enter into the patient's mind. And regarding what you said about the stethoscope, that is very important. Many times the patients, they are cured and everything, but then the doctor hati ni dile. The doctor did not even touch me,
Yes.
did not even given the stethoscope. You said truly in gastroenterology, what is there to get information on applying a stethoscope on the abdomen? But for us it is nothing, but for the patient it is a world. So this empathy, which is now gradually losing from our medical community, I think this should return. Then this, along with precision and evidence-based medicine, will become a win-win situation. Otherwise, we will lose the artificial intelligence and whatever will take over.
Thank you.
Thank you for the wonderful presentation.
Thank you for choosing this topic.
May I pass a comment, sir?
Thank you, Tribani ma'am, for your excellent lecture. I have a question to ask you. Suppose an elderly patient, bedridden, affordable patient, should we consider for going for tube feeding patients, should we consider the blenderized tube feed or the formula tube feed which you have mentioned? Which one would be better, blenderized or the tube or the formula feed?
Generalize, like Somnath, Dr. Somnath, please just explain to me, like, what do you exactly mean by the generalized? You're saying?
Blenderized.
Or blenderized.
Blenderized tube feed or a formula tube feed.
Okay.
Elderly, bedridden,
yes,
affordable patients.
Yes.
Which would be better?
Okay. Like, blenderized feed, if the person is taking from a kitchen feed, okay, like it has to be properly calculated, like whether the calorie intake which is required, okay, when we find out the calorie intake, which I had mentioned in the formula, okay, so suppose he requires 1500 kilocalorie, and if you're giving him in a blenderized form, you'll have to know like exactly how much kilocalorie the person. Otherwise, that is not a bad idea if the dietitian helps us, or if we can find out the blenderized diet with a proper calorie intake. Otherwise, if we cannot do that, then we have to go for the supplement or the formula feeds. That will help us. So if we are not very sure about the calorie, how much protein, how much carbohydrate that blenderized diet has, then we can go for the formula feed.
Any more question?
I'd like to add, this is a new, I think so, this is a concept which is coming, where Somnath. The blenderized feed is probably better. But the problem is, when you use a feeding tube, that's a different. We are using a Riles tube. In a Riles tube, blenderized feed going there is very difficult.
Very difficult, and there's a thing of tube clogging. And there'll be, gastric retention is usually there in these cases. So there are chances of regurgitation and aspiration also. So these are the things. And whenever we are giving a formula feed, we'll have to be very sure about the water quantity of that feed. Like whether, like, what we had said about the 71 grams of 8 scoops has to be in a 200 ml of water. So even if the water content is less also, the same thing happens there. But for the blenderized too, there are these problems.
Yeah, blenderized, as soon as the patient can take orally, then probably blenderized.
Yes.
Blenderized in the tube also is like evidence, sir is saying, this is evidence-based that this is better, but actually practically giving it through the Riles tube, have you tried? It's very difficult giving a blenderized
It's
unless
very difficult.
you have
There's
no
a tube
vegetables.
clogging.
Very difficult. I think so, ruling out time. But it is, both options are good enough.
Thank you.
Is there any question? No. So thank you very much for both the speakers. They have excellent deliberation. And what I can remember, my teacher says always that medical science is not a pure science. It is a combination of science and arts. So science is the evidence base, and arts is the healing touch. We have to be, make them equalize. If we don't touch the patient, patient is not going to be cured according to them. Because I also still remember, once a patient came, he had a headache. Sir, believe me, he said, sir, you did not put the stethoscope on my head, because my problem was in the head. So I was forced, then only smile came to his face. So this is unethical, but this is the arts. We have to make the patient happy with the medicines as well as our healing touch. So thank you very much, sir, for your nice deliberation, Dr. Tribini Sharma, and thank you, the organizer, for giving us this opportunity in the morning to conduct this session. And thank you, the house, for a nice interaction. Thank you. Now we conclude the session here.
Thank you so much, respected faculties, respected speakers and chairpersons. It's my pleasure to invite you to pose for a group photograph. Meanwhile, we'll have the next session. The next session is ICP Program 2. To chair the next session, I would like to call upon stage Dr. Swarupjyoti Soikia, Dr. Prashanta Goswami, Dr. Paresh Sharma, Dr. D.K. Bhattacharjee, Dr. Rajiv Barbara, and Dr. Ajay Peter Topno. May I request the chairpersons to kindly come up on stage. Thank you so much. And before I hand over to the chairpersons, I once again, from the core of my heart, acknowledge your cooperation in maintaining the time schedule. Let's hope we can continue like this. Thank you. Now hand over to the chairpersons.
So we'll start the next session. The first topic will be fever of unknown origin, rheumatic differentials, will be delivered by Dr. Prashanta Dihingia, who is a professor of medicine, Assam Medical College. Over to Dr. Dihingia.
Respected chairperson, respected my teachers, my colleague and student friends. And I'm very much thankful to the organizing committee because they are giving me the chance to stand here. My topic of today's CME is fever of unknown origin, rheumatic differentials. A female patient, 30 years of old, came to our OPD with chief complaint of fever with headache. Fever is on and off for 2 months. For this, she was treated at a local hospital but did not get relieved. We re-evaluated the patient through proper history, physical examination, and routine investigation as well as fever profile. Investigation revealed pancytopenia, raised ESR. Entire fever profile was negative. Routine examination of urine showed albuminuria, 3+, looking at the chronicity of the fever, and based on our suspicion of some kind of autoimmune disease, as she was a female patient, we sent ANA profile on second day. To confirm our suspicion, 5 days after admission, patient developed a typical malar rash. Following this, we started her on a steroid of 1 milligram per kg of the body weight. On 7th day, her fever subsided and total count increased. On same day, report of ANA immunofluorescence came, which is positive with fine speckle pattern. Following antibodies were present, anti-Smith, Rho52, Rho60 UNRP, and thus the patient was diagnosed as SLE. Fever of unknown origin, definition. It is defined as a temperature greater than 38.3 degrees centigrade, accompanied by more than 3 weeks of illness, failure to reach a diagnosis after 1 week of inpatient investigation. It is divided into 3 main groups. One is infection, malignancy, non-infection inflammatory disease, and miscellaneous. Rheumatological diseases are grouped under non-infectious inflammatory diseases. It consists of vasculitis, connective tissue disorder, granulomatous disease, and others. From the literature, it shows that 30% of fever of unknown origin is from non-infectious inflammatory disease. Takayasu arthritis. High suspicion of Takayasu arthritis is from fever of unknown origin. Patient's age is less than 40 years, female, claudication of the extremities present, decreased percolation of brachial arteries, bruit over subclavian artery or abdominal aorta. We re-evaluated the patients of fever of unknown origin. If all are negative, we go for the ANA profile. If ANA profile is also negative, we go for the ANCA profile. If ANCA is also negative, if we clinically suspect the patient, we may go for biopsy of the vessels. If clinically suspected, from the history and all clinical findings. Giant cell arthritis. Fever is presenting feature in 50% of the cases. Giant cell arthritis should be suspected if fever is associated with superficial temporal artery thickening. Polymyalgia rheumatica, fever occurs in 33% of the cases. Polymyalgia rheumatica should be suspected if fever is associated with musculoskeletal pain, which worsens with movement. In giant cell arthritis, the fever is very low grade. In the very initial stage, it is present. Fever usually does not exceed 102 degrees Fahrenheit. In polymyalgia rheumatica, it is a first symptom in some patients presenting with fever. The others is polyarthritis nodosa. It is also medium vessel vasculitis. Fever with severe myalgia or lower limb tenderness and testicular pain should raise the suspicion of polyarthritis nodosa. Kawasaki disease. Patients have fever with rash with non-purulent conjunctivitis. There is cervical lymphadenopathy, redness in oral cavity. Polyarthritis nodosa is a first symptom presenting with fever. Though the fever is not low grade, but sometimes it exceeds 102 degrees Fahrenheit. In Kawasaki disease, it is usually the fever is very high. It is more than 104 degrees centigrade. It at least persists 3 days. The Kawasaki disease present with rash, mainly the rash is in the tongue or in the genitalia, and also there is inflammation in the conjunctiva presented with conjunctivitis, but it is non-purulent. There is cervical lymphadenopathy. There is redness in the oral cavity, the redness mainly in the tongue, which is called strawberry tongue. Microscopic polyangiitis, it is small vessel ANCA-associated vasculitis. Granulomatous disease with polyangiitis, Sachs-Stuck syndrome is also under this small vessel vasculitis. But here the fever unknown is very rare, but sometimes they are presenting with this. So when it is presented with, there is some other flu-like symptom in case of microscopic polyangiitis. In granulomatous disease, when presenting with fever of unknown origin, there is some long prodromal stage in case of granulomatous disease, Wesner granulomatosis, sorry. Hanoscolian purpura. Fever is very infrequent, but sometimes present with this. When fever, the child is less than 15 years, present with fever, there is abdominal lump, arthralgia, palpable purpura, hematuria. Hanoscolian purpura should be the first rheumatological defense cells. So where in the literature said, the hanoscolian purpura, when it is presented with fever of unknown origin, mostly from the thrombosis. The literature says the thrombosis mainly the splenic vein. Next is Behçet's disease, small vessel immunocomplex, presenting with oral ulcer or genital ulcer, uveitis present with the fever. But it is here we will get usually the periodic fever. When it is not, so you can suspect it is a fever of unknown origin. Connective tissue disease, systemic lupus erythematosus. Fever may be the first symptom of lupus. It is one of the common causes of fever of unknown origin. Fever in lupus patient is mostly because of two reasons, either a flare-up or a overlapping infection. So persistent fever, known as lupus fever, it is throughout the disease it presents. Though it is a low grade, it usually exceeds 102 degrees Fahrenheit. So when a patient is a connective tissue disease, we have to exclude from the investigation. It shows pancytopenia. There is pancytopenia, routine examination, it shows the albuminuria, and there is RBCs in the albumin. So when patient presents in connective tissue disease, so you are to presenting with joint pain, we have to see the rheumatoid factor, anti-CCP, and HLV27. Most of the patients of ANA gives the diagnosis of connective tissue disease. Idiopathic inflammatory myositis, polymyositis, and dermatomyositis are characterized by proximal muscle weakness and myalgia. Fever is present with some other constitutional symptoms. The other constitutional symptoms are arthralgia, myalgia, anorexia, and there is morning stiffness. These things are usually there. But in case of when patient presenting with fever of unknown origin, there is always anti-synthesis antibody, that is anti-ZO, usually it is present in case of inflammatory myositis. Sjogren syndrome, lymphocytic infiltration and destruction of the exocrine gland occurs leading to dryness. Fever is very unlikely, but when this type of Sjogren syndrome, when it proceeds or there is a chance of progression to lymphocytic proliferative of the neoplasm, that may present with fever of unknown origin. Rheumatoid arthritis is rarely present, but when it is presented with vasculitis and Feltis syndrome, you can think of the fever of unknown origin. Spondyloarthropathy. Among spondyloarthropathies, reactive arthritis is usually present with the tri, uritis, conjunctivitis, and fever, and arthritis with fever. Next one is sarcoidosis. Occasionally, it can present as a diagnostic challenge in a patient with fever of unknown origin. If fever present, the patient has Lofgren or Hereford syndrome. In this fever, there is a major constitutional symptoms along with other associated symptoms. The associated symptoms are nitrates, arthralgia, myalgia, and there is dryness in the eyes. So these things are usually present in sarcoidosis. We should go for see the fever profile at the time, but of unknown origin. You will get the lymphocytosis, usually it is present. You will go to calcium level, increase serum calcium level. So you can do for the bronchoalveolar levels for CD4 and CD4 ratios to see. If it is not there at the time you suspect clinically, so you should go for the gallium scan which shows the Panda sign. So this is very, very important. The other important is Lofgren syndrome. The Lofgren syndrome is acute sarcoidosis. It is presenting with bilateral lymphadenopathy, hilar lymphadenopathy, and there is fever and polyarthralgia and polyarthritis. It is usually present. In Hereford syndrome, there is bilateral parotid gland swelling, and there is fever and facial nerve palsy. So this is presenting with fever. So it is important in sarcoidosis. Adult onset disease, though it is rare, a major cause of fever of unknown origin. Various literature says fever has very specific feature. It is greater than 39 degrees centigrade, follows a quotidian or double quadrant fever. Crystal indices is rarely present, but if you presenting with a swollen zone, we think of septic arthritis, best to do arthrocentesis. Most patients with bacterial arthritis presenting with fever, best way to establish bacterial arthritis as a cause of fever of unknown origin is to do arthrocentesis. If fever is low grade, associated with neck pain and arthralgia or myalgia with bullseye, so you see suspect the Lyme disease. Arthritis with Mycobacterium tuberculosis may also present with fever of unknown origin. The typical character of fever is on evening rise of temperature. Viral arthritis may sometimes present with fever of unknown origin. In case of, you think of the reactive arthritis includes in fever of unknown origin or with infection. So reactive arthritis usually present, because I have told about the classical triad. So in case of viral arthritis or in case of viral fever, so most of the patients, they are presenting with severe myalgia. Rheumatic fever is an inflammatory disorder caused by a group of Streptococcus throat infection. Modified Jones criteria used for diagnosis. Most common is cardiac involvement associated with fever. So if you know a patient is having fever of unknown origin, how you proceed? If fever is more than 38.3 degrees centigrade, illness is more than 3 weeks with no immunocompromised state, history and physical examination to do. Stop antibiotic treatment and corticosteroid. All investigation for fever profile like CBC, ASR, 3 blood culture, all have done. At that time, the next step is to exclude manipulation with thermometer. Stop or replace medication to exclude drug fever. If potential diagnostic clue present or if potential diagnostic absent. If present, so guided diagnostic is to do to achieve diagnosis is achieved. If potential diagnosis is absent, so at that time you go for a cryoglobin and fundoscopy. So FDG PET, CT, or level leukocyte scintigraphy. If scintigraphy is normal, confirmation by abnormality by biopsy or culture, diagnosis is achieved. Scintigraphy normal, review history, physical examination, and PDC driven invasive procedures, so diagnosis is achieved. If not achieved, we should go for CT and abdominal, abdomen and CT of thorax to do. If patient is having more than 55 years, temporal biopsy to do if needs, diagnosis achieved. If patient is stable, follow up for new PDC and consider NSIDs. If patient is deteriorating, so further diagnostic test to do, consider therapeutic trial. So now we are going to conclude the subject by approximately 30% of the fever of unknown origin will eventually be diagnosed with a rheumatological disease. Presentation of rheumatological diseases are mostly non-characteristic, thus diagnosis is challenging. Potential diagnostic clues should guide the investigation. Immunologic serology such as ANA, anti-DS DNA, and ANCA should be repeated with strong suspicion is present based on history and physical examination. Treatment with anti-inflammatory drugs should be postponed as much as possible until the diagnosis is made, as it may mask the PDC. Thank you for your patient hearing. It is an old temple from Shivsagar Shiva temple. The another one is 10 years back made the Jagannath temple. Thank you in Dekargaon. Thank you. Thank you.
Thank you, sir, for your very lucid presentation. I think there is some announcement. I would like to give time to Dr. Sikriti.
Sorry for the interruption, but there is a small announcement to make. Updates will be available in Microlab stall. It will be distributed in the Microlab stall, and the souvenir will be distributed in the Signova Pharma stall. Thank you so much.
Thank you. Now for the second talk, I would like to invite Dr. Moromidas Madam. She'll be talking on the topic, first seizure, approach and management. It's a very practically relevant topic. Many of us, during our practice, we are in a dilemma whether the abnormal body movement that the patient has presented with is really a seizure or not, and when to treat the seizure. So I think Madam's presentation will make these things clear. So I would like to give time to Madam.
Good morning, respected chairpersons and distinguished audience. First of all, I thank the organizers for giving me this opportunity. The topic allotted to me is first seizure approach and management. As we all know, the first seizure is a potentially tragic life event, can result in physical and mental harm, employment loss, and social prejudice. Risk of single lifetime seizure in the population at large is around 10%, and chance of epilepsy is around 3%. Experiencing the first seizure is frightening event, not only for the patient, but also to his close associates like his friends and family members. How do we define seizure? Seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, and synchronous discharges from a group of cerebral cortical neurons. Whereas epilepsy is defined as 2 or more unprovoked seizures occurring in 24 hours apart, or one unprovoked seizure, and risk of subsequent recurrence is that after happening of 2 unprovoked seizures, that is around 60% at 10 years, and 1 unprovoked seizures, and if the patient is diagnosed with epilepsy syndrome. Then coming to semiology, what do you mean by semiology? Semiology means what exactly happens at the time of seizures. Depending on whether the abnormality starts in the focally in the brain or diffusely, the seizures may present as focal or generalized seizure. Again, we know that there in the brain, different areas carry out different functions, and body part representation, that is homunculus, is although it looks similar, but is different for motor and sensory areas. So depending on which part of the brain the seizure focus starts, the patient may present with various signs and symptoms. Little bit about the classifications. Seizures have been classified way back in 1981 by International League Against Epilepsy, and from time to time there are modifications. This is the latest classification occurring in 2017, where the seizures are classified into focal seizure, generalized seizure, and unclassified seizure. All three are again subclassified into motor onset and non-motor onset. Again, the focal seizures are subclassified into focal seizure with awareness, preserved awareness, and focal seizure with impaired awareness, previously known as simple partial seizure and complex partial seizure. Focal seizure is again can go into bilateral tonic-clonic seizure, that is previously known as partial seizure with secondary generalization. Another term I want to highlight is symptomatic seizure. This is an umbrella term that encompassing provoked seizure, which occurs in relation to substance abuse or intoxication or withdrawal, like alcohol withdrawal, or concurrent metabolic derangement, like electrolyte imbalance, hypoglycemia, hypocalcemia, hypomagnesemia, etc. It also includes acute symptomatic seizure that occurs within 7 days of acute brain injury, like traumatic brain injury or acute encephalitis, and remote symptomatic seizure, that is a delayed seizure that occurs after a brain insult which has occurred long back. Then when approaching the patient with first seizure, first of all, we should remember the first seizure might not be actually a seizure. Okay, so there is a long list of indications where these are seizure mimics, and two conditions we find very difficult in clinical day-to-day practice is an elderly patient when they present as seizure-like manifestation, we have to differentiate it from cardiac syncope, and a young girl when presents to us with seizure-like manifestations, which can be actually a psychogenic non-epileptic seizure known as PNES. So differentiating between the epileptic seizures and the syncope, the important differentiating points is that in case of epileptic seizures, many may have a history of aura like epigastric rising sensation, some taste or smell abnormalities, whereas in syncope, prior to the onset of unconsciousness, there may be visual or auditory fading, blurring of vision, pallor, there may be sweating or palpitations. Duration of seizure is usually in minutes, and duration of syncope is usually in seconds. Tongue bite, especially lateral tongue bite, is characteristic of very highly specific of seizures. In syncope, tongue bite usually does not occur, but if occurs, patient beats the tip of the tongue. And post-ictal confusion characterizes the seizure episode. Then differentiating psychogenic non-epileptic seizure from epileptic seizure, PNES is usually occurs in presence of the family members. Patient have closed eyes, they have resistance to eye opening, the seizure manifestations are not stereotyped, there may be pelvic thirsting, and of course the lateral tongue bite, which is very much specific for the seizure, is not seen in psychogenic non-epileptic seizure. Then the second point we should remember that a first seizure actually may not be the first seizure, because the patient or parents have missed some your history. That history should always be taken from the eyewitness, and we should take a detailed history in, regarding any past history of epigastric rising sensation, any smell or transient smell or taste change before the attack, or if there is history of any early morning myoclonus or absence. Like I want to show this boy who has presented to us with a history of scholastic decline, and we suspected an absence, and look at, we have hyperventilated, and look at the very minute seizures. So these are often missed by the teacher or the parents. Next is your clinical examination. Whenever a patient with a history of seizure-like phenomenon comes to us, we should always thoroughly examine the patients regarding the pulse, the blood pressure, any evidence of tongue bite or cheek bite, any injuries, and thorough cardiovascular and neurological examination, and we should examine the skin properly. Like this young girl who has come to us with one seizure, look at her in and around the lips, there are some skin lesions. But when we saw the mother, She is having the typical angiofibroma of tuberous sclerosis, and she is suffering from a neurocutaneous disorder called tuberous sclerosis, and high likely of having epilepsy. And so this girl, even if she comes with one seizure, we are going to treat her as epilepsy. Then after history and physical examination, also we have to identify acutely provoking and triggering factors. Like in child, we have to look if there is high fever, and in adults, if there is significant sleep deprivation, withdrawal or intoxication of any drug, hypoglycemia, electrolyte imbalance, if the episode has occurred in acute brain insult, and we should not forget some medication that reduces seizure threshold. Very commonly used medications like tramadol, like antibiotics like fluoroquinolone group of antibiotics, penicillin group of antibiotics, bronchodilators, muscle relaxant like baclofen, even local anesthetic, they can precipitate a seizure in case of a susceptible individual. Then after history and physical examination, we should perform comprehensive diagnostics, complete blood counts, glucose level, renal and liver function test, serum electrolytes, mainly sodium, calcium, and magnesium, ECG, early standard electroencephalography should be done as early as possible, preferably within 24 hours, because chance of finding the abnormality in the EEG, it is around 50% if done within 24 hours, which go down to half if we delay by another 24 hours. That means within 48 hours, it comes to half of the abnormalities. So if there is focal seizure semiology, we should go for neuroimaging. A 3 Tesla MRI brain is far more good for detecting small cortical lesions like cortical dysplasia, and where it is not available, we can go for CT scan brain. And when we suspect infection like meningoencephalitis, we should advise the lumbar puncture and CSF study. Then a special note about the elderly, that if an elderly person comes and we think that he is suffering from seizure, we should remember that usually seizures occur at the background of cerebrovascular accident in case of elderly persons. So in addition to anti-seizure medication, we might have to give him stroke prevention medications. So before going to treatment, we should counsel the patient, and in case of children, we have to take into account the parents, or in case of adults, we have to take him in the whole process. Like we should explain regarding the diagnosis and types, regarding the recurrence, and then regarding the prognosis of underlying etiology, safety considerations, then what will be the lifestyle modifications, and how he should avoid those factors that increases seizure risk for him. Why you should treat after a first unprovoked seizure? It has been found in a meta-analysis that the risk of recurrence after a first unprovoked seizure is around 42% in the first 2 years, and within 60 to 70% of the recurrences occur within 6 months of the first seizure. So we have to treat it in some cases. But all the seizures might not need treatment. But is there some predictors which can predict that he might need long-term medications? So if the patient is having underlying brain pathology, if the patient is intellectually disabled, if there is focal seizure phenomenology, if there is focal neuroimaging problem and EEG findings, and nocturnal seizure, we should remember that if the person, even with one attack, he presents that the seizure has occurred while he was asleep. So nocturnal seizures, these are high likely that this might have underlying epilepsy syndrome, because there may be a part of a syndrome called autosomal dominant nocturnal frontal lobe epilepsy. And other investigators have found that if the patient had multiple seizure recurrences within the first 24 hours, if the first seizure presents as status epilepticus, if the patient has history of febrile seizures or family history of seizures, these might be another predictors that can predict the recurrences of the seizure. Then what are the indication of anti-seizure medication? We have already mentioned those factors, they are predicting the recurrence, that they should be treated. And also if there is a history of remote symptomatic lesion, and a corresponding epileptiform EEG activity. If there is underlying high-risk brain lesions like abscess or venous sinus thrombosis, if the patient has high risk of loss of employment with further seizure, if the patient is a student and he is staying in the hostel with unshared accommodation, we can start with the consultation with the parents. And where the patient is suffering from this such medical and social condition that another seizure will harm him, then we should start anti-seizure medications. Then while choosing the anti-seizure medications, we should mainly look about the semiology, whether the seizures are focal or generalized. We should look about the efficacy of the drug and the tolerability. Then we should choose a drug with low interaction profile. And also we consider the gender, comorbidities, and aesthetic issues, especially in ladies, like weight gain, and then other side effects. And of course, last but not the least, regarding the socioeconomic condition of the patient and availability of the drug. Usually in all seizure types, sodium valproate, levetiracetam, brivaracetam, lamotrigine are the drug of choice. In absence, only the ethosuximide is the drug of choice. In focal or focal to generalized seizures, carbamazepine, oxcarbazepine, phenytoin, lacosamide, perampanel, these are the drugs are used. We should also remember the common side effects like weight gain, hepatotoxicity, tremor, hair loss, especially in case of valproate, gingival hyperplasia in phenytoin. We should not forget the Stevens-Johnson syndrome and skin lesion in sodium channel blockers like carbamazepine, oxcarbazepine, phenytoin, etc. So, but treatment has to be individualized, and as I have, again, I'll emphasize that patients or parents has to be taken, they should be with us during the whole process. Then how long to treat? If we consider that it's epilepsy, we have to treat 3 years. In case of acute symptomatic seizure, treatment should be given till the underlying condition is corrected. So it has been seen if we treat the patient within the first attack after the first unprovoked seizures, or we wait for the second seizure to occur and then give treatment, it has been found in studies that there is statistically reduction of recurrences within first 2 years. But long-term quality of life and long-term prognosis does not differ whether we start the treatment after the first attack or we wait for the second attack. Then, so summarizing, when a patient comes to us with paroxysmal manifestation, first of all, we have to rule out the seizure mimics. Then, if it is a seizure, we should find out what type of seizure it is. Is it an unprovoked seizure or it is an acute symptomatic seizure? If it is unprovoked seizure, we have to try to classify and we choose the anti-seizure medication accordingly. If it is an acute symptomatic seizure and if it is a provoked seizure, like it is occurring in the background of substance intoxication or hypoglycemia, like metabolic derangement, we should treat the cause and we should not, anti-seizure medication may not require. But if it is occurring with an acute brain insult like herpes simplex encephalitis or acute traumatic brain injury, then it might need anti-seizure medication depending on the cause. So this study was published last year from our department. We tried to see 70 cases of first unprovoked seizures. We found a generalized tonic-clonic seizure being the maximum number, and 50% was acute symptomatic seizures, and about 1/4 of the patient recurred within first 6 months. So summarizing, so we should not miss the first seizure. Initiation of anti-seizure medication is not recommended in all cases, and recommendation of the treatment must be individualized and must take into account of medical, social, and financial implications of those who have experienced the first seizure. Thank you very much.
Thank you, Marami. You have covered almost all the points. Thank you for the excellent presentation. We'll take the questions after the session. So the next topic is myths and facts about snake and venomation, will be delivered by Dr. Nandini Chatterjee. So this is a very important topic for physicians. Over to Dr. Nandini Chatterjee for
Good morning, everybody. I thank the organizers of Assam APICON for inviting me here today. I also specially thank Dr. Dijen Dash for his excellent hospitality. Today, I have chosen a topic which is very common, and whatever I will be discussing today is not new to you. It will be a recapitulation because primarily snake bite is shrouded in mysteries and prejudice. And it is important that we should be knowing the bare minimum facts and able to recognize the myths about snake envenomation. So, snake envenomation has been designated as a neglected tropical disease by the WHO in 2009. However, we all know that it is a very important public health hazard in tropical and subtropical countries, and the estimated number is about 5.4 million incidents every year. I will be dwelling upon various aspects of snake bite, and for this I begin with a case. A 45-year-old farmer was brought to the emergency with a history of snake bite when he was out in the fields 2 hours ago. He has not seen the snake but felt the bite. His friends have applied some herbal medicine and tied a tourniquet over his scarf. When he is examined, it is found that he has an anxious face, he has a pulse rate of 100 per minute, a slightly raised blood pressure. There's a bite mark on his right great toe, but there is no swelling or erythema. There are 2 tight cloths wound around his calf and ankle. So, taking into account this scenario, which I'm sure many of you have encountered in your hospital practice, I will emphasize on the fact that unlike this patient, most of the snake bite victims, they initially seek non-medical help. Traditional healer will see the patient first and then they will come to the healthcare facility. So only 22.19% of the snake bite victims are taken to healthcare facilities. So the common Indian venomous snakes, namely the Indian cobra, the Indian krait, the Russell's viper and saw-scale viper, we know about them, but it is important to ask, are all snake bites venomous? They are not. We should remember that only 30% of the bites are by venomous snakes. There are 300 species found in India, of which only 52 are venomous. And sometimes even a venomous snake may bite, but the venom may not be injected into the wound. That is called a dry bite. So, when you encounter a patient, the first thing is to reassure the patient, because in 70% of the cases, the snake bite may be non-venomous. Now, our patient, as I mentioned, has had 2 tight pieces of cloth tied around his calf muscle. So, is it helping him? Is a tourniquet helpful in preventing systemic envenomation? Well, the answer, as we know now, is that it does not help. Tourniquets should not be tied, as the blood supply may get obstructed, leading to gangrene even. Any constricting clothing or jewelry also should be removed for the same reason if the limb or the digit starts to swell up. The limb where the snake has bitten needs to be immobilized with bandages or cloth to hold a splint, but without applying too much pressure. When the patient has reached the hospital or reached you, care must be taken when removing tunicates, because sudden removal can lead to a massive influx of venom, leading to hypotension or paralysis due to vasodilatation. Also, another word of caution: before removal of a tourniquet, it is important that you look for the pulse distal to the tourniquet. If the pulse is not palpable, then a blood pressure cuff needs to be applied, and gradually you reduce the pressure and remove the tourniquet. So number one, no tourniquet. And number two, if there is a tourniquet, even the removal should be with great caution. I also mentioned that in our patient, the great toe contained the fang marks. However, it is important to note that that fang mark, is it very important that we find the fang mark? Again, this is not so, because a group of snakes, the crates, they often do not leave a fang mark. This is one. So in that case, you need to have a high index of suspicion. If that area has reported various snake bite cases, or it is a common occurrence during the rainy season, it has to be in your mind that this could be a case of snake bite, even if you don't have a fang mark. The patient may come with a ptosis, patient may come with an abdominal pain, and there will be a history that everything started suddenly when the person had gotten up from the sleep after sleeping on the ground, maybe outside the house. So all these histories would make you suspect not the presence or absence of a fang mark. Moreover, a fang mark, by seeing the fang mark, you cannot get any clue whether the species is venomous, or what is the amount of venom that is injected, or what is the severity of systemic poisoning. Next, is there any benefit of washing, sucking from the wound, or electrocuting the wound of a snake bite? Again, there is no benefit. The wound should not be interfered with by any procedure. We just put the limb in an immobilized fashion in a splint and bring that person to a health facility. First aid methods like herbal therapy have no role and may do more harm. Immediately after providing first aid, the patient needs to be transferred to a health facility. This is very important, and the health facility should have provision of anti-snake venom. We need close observation of the patient, we need the basic laboratory investigations to be done, and we need to quickly give resort to proper treatment. Now, how to arrange for transportation of the patient? Well, the patient may have a small bite, maybe on his finger. Then it is separate. But if the patient's bitten limb is the lower limb, that patient should not walk. Urgent transportation of the patient to a medical facility is to be by carrying. So the patient should go in a vehicle, a boat, a bicycle, a motorbike, a stretcher, whatever is available, but the patient should not be walking. What is the protocol on admission? It is the dictum that all victims of snake bite, either confirmed or suspected, are to be observed for 24 hours. Suppose a patient comes to you who is not looking ill. He says that I was bitten by a snake, but you see his vitals are fine, he has no ptosis, he has no bleeding. So you say, acha, okay, you go home. It is not to be done. And why is that? Because sometimes the effects of envenomation are delayed. So a neuromyelitic snake bite patient may present within 6 hours. So our patient, as you remember, has come within 2 hours. So he may be developing some problem after a few hours. So you need to monitor and observe him. Crate bites are even more dangerous. Why? Because first, there is no bite mark. You are just clinically suspecting. Moreover, it has been found that ptosis in a crate bite has occurred 24 to 36 hours after the bite. So again, here lies the importance of observing your patient. Observation is to be followed by the most important investigation, which is very easily done in our wards, that is the 20 minutes whole blood clotting time. After the results of this WBCT, you will decide whether to give the ASB therapy or not. There is no role of injecting the ASV at the site of the wound. So, to emphasize again, we need to look for the signs of envenomation. So, how does a patient of snake bite present? They can present with neuroparalytic symptoms and signs. They can present with bleeding. Myotoxic snake bites may come with muscle weakness, and also some patients can come with progressive local swelling and lot of local reaction at the site of the bite. Now, what are the markers of envenomation? It is very important for our residents and all our physicians to be able to recognize the signs of envenomation. The local signs, which are very prominent in case of the viperine bites, is swelling, bleeding, blisters, and necrosis, which may develop within a few hours. It is said to be very significant if it is progressing very fast or it is involving more than half of a bitten limb. Hematotoxic effects are the signs of DIC or venom-induced consumptive coagulopathy. Here, there may be bleeding from various orifices, gums in the eyes, or the patient may have a hematemesis even. All these you have to take into account. If your patient comes with these, then you have to institute immediate ASV administration and other supportive therapy. Involving the cardiovascular system, some of the symptoms like hypotension, arrhythmias, and abnormal ECGs can be reported by snakebite patients. There can be acute renal failure, acute lung injury, and capillary leak syndrome. How many minutes do I have? 2. So I will rush through. So neuroparalytic features, not going into the details, you have an idea. But one thing must be stressed, are all symptoms due to envenomation? I must stress that all are not due to envenomation. Sometimes sympathetic overactivity can manifest with various symptoms like palpitations, sweating, tremulousness, etc. Our patients showed no signs of envenomation on admission. So what to do next? So we had done and will be doing the 20-minute whole blood clotting time. One thing I have to say, that when you draw the blood, it should be in a glass test tube, observe for 20 minutes. If the patient has a hypofibrinogenemia, there will be no clot. How frequently will you monitor the patient? You are keeping him or her for 24 hours at least. You check the pulse, respiratory rate, the BP, and the WBCT hourly for the first 3 hours. So initially it's very frequent, every hour, and then every 4 hours until the remaining day. Our patient was discharged after 24 hours. I have written an extra line here that if he had presented late, his complications would have been due to the tourniquet that was tied and not due to the snake bite. Scenario 2, same patient. In the first one, no signs of envenomation. In the second one, The great toe has severe pain. There is swelling, erythema, and a swollen feet. So here, quickly assess the patient. Yes, I'll stop. Okay, I'll take a few minutes just to quickly go through. So this is the assessment, vitals, 20-minute WBCT, and how to identify impending respiratory failure. This is very, very important. In the ward, do the single breath count. Your normal patient will be able to count in one breath up to 30. Breath holding time. Ask the patient that you hold your breath. A normal person will have more than 45 seconds, he will be able to hold the breath, and he will be able to complete a sentence in one breath. So if your patient fails on any of these counts, you know that you have to either refer the patient to a higher center or you have to send him to the ICU. We have to urgently administer the ASB. Another very important thing, no test dose is necessary. It's a myth that you have to do a testing. In fact, it is harmful because it may pre-sensitize the patient and lead to future hypersensitivity reactions. 10 to 30 vials. Now, you do not go on giving ASV. There's a limit to it. For hematotoxic, it's below 30 vials, and another thing, for pregnant and children, it is the same dose. This is very important. The adult, the pregnant, and the child will have the same ASV dose. Is species identification necessary for treatment? No, it is not. You have to rely on the clinical features. One thing is that ASV is not effective against all venomous snakes, and there are certain snakes in different districts which are not very responsive to our polyvalent ASV, like the Kalach in West Bengal and some pit vipers present elsewhere all over India. So, due to paucity of time, I'll come to the take-home messages. Snake bite is a threatening health hazard. There is no role of a tourniquet, no role of a herbal medicine. You have to observe each and every patient of snake bite for at least 24 hours. Crate bites are the most dangerous because they do not have fang marks and mimic other diseases like pancreatitis or appendicitis initially before developing ptosis, which may delayed after 24 hours even. Optimum ASV doses should be between 20 to 30 vials, and if properly managed without prejudice, morbidity and mortality can be significantly reduced. Thank you.
Thank you, Madam, for your very informative presentation. I would like to request you to please take a seat. And before taking any questions, 1 to 2 questions we'll take. Before that, I would like to invite the previous speakers, Dr. Prasanto Dhingia, sir, and Dr. Moromi Das, madam, to the stage, please. So I invite 1 or 2 questions from the house.
You. An excellent presentation. I have one very small question to Madam Nandini. Just while talking about the dry bite, dry bite means no venom injected into the wound. Now, would you treat such patient with an animation, or would you go for a treating? And how do you diagnose in dry bite?
Thank you, sir, for this very important practical question. The thing is that we do not know whether it's a dry bite or it's a venomous bite. So our only indicators will be the clinical presentation of the patient and the WBCT time. Whatever the bite, we admit the patient, we clinically examine, look for ptosis, look for the history of any bleeding coming from anywhere, what is the urine output of the patient, what is the local reaction developing within maybe 4 to 6 hours. Initially, there may be nothing, but if you observe every hour, then if you see it's swelling up, it's progressing, then you start, and you, also the main indicator is the clotting time. If your blood is clotting, repeat it. We have to repeat it hourly for 3 hours, as I said, and then after 3 hours, if it's negative, you still go on repeating it every 4 hours. So we are not depending on our instincts whether this is dry or wet. We are depending upon the clinical manifestations of the patient.
Madam, just I'd like to ask whether it is 30 minutes WBC clot time or 1 hour till your clot appears. So I'm a little bit confusion. Like
20 minutes, sir. The name is itself 20-minute WBC.
No, you got to repeat every after 30 minutes after doing that or 1 hour.
Okay, so I have taken this from the WHO guidelines, and where it is saying that hourly for 3 hours, and then you may be speaking from some other.
Yes, our Indian guideline. I am
Indian
talking about
guidelines.
our Indian guideline. What they said ki you got to do every 30 minutes.
Yes.
Then
one thing is, sir, if your first WBCT has not clotted, so there is no point, there is nothing, so you immediately administer the ASV. This question arises only if you are not getting any clinical symptoms. Suppose your patient is fine, yet you want to observe, so there. However, what I should say is that always your clinical judgment is of prime importance. What is the locality in which you are practicing? Whether you are getting many cases which go on to get complicated, so you can go for. So if you are saying 30 minutes, there are different guidelines, so it may be.
Thank you, ma'am.
Thank you.
My question to Dr. Prasanta Dihingia, who has presented excellently that fever of unknown origin, breakdown or rheumatism. That, sir, you have not included that drug-induced fever, drug-induced rheumatism, mainly drug-induced SLE and all this. These are also important cause of fever in relation to rheumatism and fever of unknown origin.
Yes, you rightly mentioned. So I exclude some slides today because when I am preparing the slides, Dr. Dijan said that you have to, at least you have to fix the slide below 20 slides because you have to finish in time, in 15 minutes. So therefore, I excluded, you rightly mentioned. So drug fever is a very important drug causes the vasculitis, mostly propylthiouracil, hydrantoin, and hydralazine. These drugs is mainly, they cause the vasculitis and that causes the fever. Usually they inducing the ANCA, that ANCA causes the vasculitis, so it is causes. The other some drugs are penicillin and sulfonamides. They also causes the vasculitis, and they also causes the fever. Yes, thank you.
Just I would like to ask one question to Dr. Moromi. Your talk was excellent, Moromi, and I learned a lot from your talk. Just one thing I would like to ask. Suppose a person comes with a first episode of seizure. We rule out the provocative causes, we rule out the symptomatic causes, and the person's EEG is also normal, but there is a history of tongue bite. Suppose we think clinically that it is a seizure, but his EEG is normal, and it is the very first seizure, first episode. Do we start on long-term AEDs?
Thank you, madam. This is a very tricky question, actually. If the patient has literal tongue bite, it is 100% sure that he is having a seizure. And everything else is normal, according to you. All EEG, MRI, everything is normal. Then I have emphasized that we should always take, in case of an adult, in his treatment decision, from the initial assessment, we have to include him. Or in case of child, we should include the parents. If the patient is a housewife, staying always surrounded by her relatives, we can wait for the second seizure because it has been found out that by different studies that recurrence within first 2 years is prevented by the early initiation. But after 2 seizures, if we, in the long term, it does not make a difference. But if the student is an examinee, he's staying outside in a unshared accommodation, or if he, in another, he had the first seizure at office, and office persons that his bosses told him, you cure yourself, or otherwise, if second seizure occurs, you have to leave the job. So in this, it has to be individualized from patient to patient. Of course, nowadays in case of litigation, because nowadays the new anti-seizure medications, the side effects are very less. So if you want to avoid litigation, suppose in the second seizure it had occurred in the road and there was an accident or something, so it's better, I think, so to go for a very non-toxic drug, broad spectrum medication. We can start also.
Thank you so much.
Moromi, excellent lecture. Moromi, excellent lecture.
Thank you, sir.
The investigation of choice, before it was CT, now it's a high resolution MRI?
3 Tesla MRI, because cortical dysplasias, many of the idiopathic seizures previously diagnosed as idiopathic epilepsy, now found out to be some small cortical dysplasias, and mainly they are presenting as refractory seizures.
So, high
if available, 3 Tesla MRI is better.
Okay, thank you. Dihingya, one more this thing. If the fever is prolonged and we are waiting for this thing, the investigations, would you, said 2 things. You said PET CT or a neuromuscular leukocyte scintigraphy. Yeah, which one is better actually, if both are available?
Scintigraphy, sir.
Scintigraphy is better?
Yes.
The pickup rate is much better than a...
yes, sir, FDCT.
And PET CT is a CT, but scintigraphy is a nuclear medicine test. It's a nuclear test. So that is better for...
yes, sir.
When would you like to, let's say 2 weeks, you have put up this thing for 3 weeks.
Yes, yes.
2 weeks, if you have not been, after 2 weeks, you have not been, all tests you have, whatever we can do, we have done.
Hi.
After 2 weeks, can we do it?
Yes, sir, we can do it after 2 weeks also.
But,
But usually, as we take it, is a fever of unknown origin. According to the definition, it is more than 2 weeks.
More
so
than 2 weeks. Yes. And there's a new test coming out, multiplex PCR. Where is the role of that multiplex PCR in this prolonged pyrexia?
I don't know, sir, what this.
Anyone has this idea of multiplex PCR? When should we use this? Because it's coming in a big way in the new investigations. Yes. Because what I have this thing, you have any idea? No. They are doing a test which are picking up bacteria, fungi, virus. So it's expensive, I'll say it's not very, it's around 18,000, but they have a whole list of this thing. You have given the investigations.
Yes,
yes. Multiplex PCR was not there. So
yes, sir.
I was wondering, some people have the affordability nowadays. So doing a multiplex PCR.
Sir, probably you will be able to sequence the genes of the bacteria or fungi or virus at the earliest. That will lead you to which way you should go for the detection of the
detection. And the detection time is less than 12 hours.
Yes.
Where the culture is a long time.
Yes, that is the one unique technology nowadays evolved in a very highly sophisticated area. Of course, it's not available. Some part of Guwahati probably available.
No, it's available.
Yes.
It's available in Guwahati.
So,
no, that you must use clinical acumen.
So
they'll put up all organisms will come. You have clinical acumen that this is the possible. That's possible. And one thing, to save yourself, litigation medicine, like sir was saying, better to start anti-seizure, right?
So, my one last. This is not actually a question. It is my observation, and also I am very much inclined to the snake bite. It's Madam Nandini. Particularly the crate bite in the night, there is no marks, and the patient doesn't have any sign symptoms. But slowly, even after 1, 2, or even 3 days after, patient develops neuroparalytic symptoms. And what happens? The patient, it is to be remembered always before declaring the death of a patient, because pupil will be fixed and dilated. Many cases of in crate bite, though patient is surviving. So many people, many doctors in the periphery, they declare that the patient is dead and the death certificate has been issued. After hours or say suppose 5 hours, 6 hours, patient start moving on the limbs. So this is a very tricky conditions we have observed in 1 or 2 cases. And particularly the crate bite, if there is any sign of neuroparalysis, one should always suspect that probably this is a crate bite in the evening. Patient may not notice it.
Thank you. Thank you. We conclude the session now.
I would like to request ma'am to please come up on the dais for a group photograph. Thank you, respected speakers, for a highly interactive session, and the respected chairpersons for conducting it so well. Next on the agenda, we have the rheumatology session. There will be 2 talks, an approach to arthritis, a case-based discussion by Dr. Pradeep Kumar Sharma, and minimal investigative approach in rheumatological disorders by Dr. Chiranjita Fukan. To chair this session, I would like to request Dr. Chitralekha Borua Madam to kindly come to the dais, Dr. J.D. Fukan Sir, Dr. N.G. Singha Sir, Dr. Rebecca Marak Madam, Dr. Abdul Sattar Sir, and Dr. Hilol Sarkar Sir to kindly come to the dais and chair the session.
In the meanwhile, there is a small announcement that the update and the souvenir can be collected from the Signova stall and the Micro stall. The update and the souvenir are available for collection from the Signova and the Microlab stall.
Next session will be on rheumatology. First topic is an approach to arthritis. It will be basically a case-based discussion, and it will be delivered by Dr. Pradeep Kumar Sharma. Dr. Pradeep Kumar Sharma, please. Dr. Pradeep Kumar Sharma does not need any introduction in this platform, and he is a rheumatologist and Apollo Actual Care Hospital. He is doing the practice. Okay.
Thank you, ma'am. Respected chairpersons, my respected teachers and seniors, and my friends. Thank you, Atul Sokia sir, Pavanida, Dipti Baido, Piyush, and all the organizing committee members for giving me this honor. But if you are expecting some brilliant cases, some unusual cases, it will be a big letdown for you, because honestly, that I have rarely diagnosed an unusual case. So most of the problems that we face in the daily OPD, these are some of that kind of patients. So when we think about rheumatology, we always talk about autoantibodies. So will you be surprised that if ANA is positive, you can rule out connective tissue disease? Is it not surprising? So this is a 7-year-old boy. He came from Juai, Meghalaya in October. He has fever for 1 year, and that fevers come periodically. It comes every month or so, and it lasts for 3-4 days. He was hospitalized many times because of fever. He had 1 episode of seizure, and he had history of generalized skin rash. We are not sure what kind of rash that is. He has history of pain in the knees also. There is no localizing symptoms, no cough, no dyspnea, dysphagia, pain, abdomen, seizure, headache, anything. There is no alopecia, edema, oral ulcer, or Raynaud's, etc. to suggest connective tissue disorders. Systemic and general examination was normal. So this is a busy slide. I will highlight, these are the investigations already done multiple times. His hemoglobin was always normal, ESR, CRP was always normal, total count was normal. Then cultures of urine was normal. Easy in that episode of seizure, he had generalized epileptiform discharges. Then expert TB, typhus, MRI brain, ultrasound, all were normal. So only 1 CRP was elevated, that was in June. He came to us in this October. His ANA was positive. And we can see that we see 3 things when ANA is positive. One is intensity, that is 3+, that means significant. One is, next you see the dilution, 1:1000. Again, that is significant. The pattern is DFS 70, we call as diffuse fine speckle. And nowadays, when ANA is positive, usually we do this ENA also, anti-ENA. Then that can be done by ELISA or line immunoassay. And that diffuse fine acyclical 70, that is positive. So he has one antibody, that is anti-DFS 70, both by immunofluorescence and by this line immunoassay. Somebody already thought that, because he has all these settings for SLE. He has fever, he has history of seizure, he had history of skin rash, he had history of joint pain. But is it connected to disease? Actually, there is enough literature. If this antibody is positive, and if it is the only antibody in that patient, that partially rule out connective tissue disease. But remember, this antibody can be positive with other antibodies also. If it is positive with other antibodies, that antibody actually takes over it. But if it is the only antibody in that patient, that partially rule out connective tissue disease. So this, we reviewed again his investigations. All are normal, echo is normal, ferritin is normal. So we treated him symptomatically. Next in the line is it autoinflammatory disease? But even to have autoinflammatory disease, his inflammatory markers should be raised at least during those fever periods. And I believe that most of the investigation, at least some will be done during those hospitalization periods. Those were also normal. And to confirm autoinflammatory disease, we have to do this whole exon sequencing. That is a costly investigation. That costs around 29,000. It is possible, even done in our hospital also. But before doing that investigation, I thought that let me follow up this patient. SLE patients, all manifestations does not need high dose steroids or immunosuppression. Like this young lady, she is recently diagnosed with SLE, and she was admitted for renal biopsy. So after biopsy, she was discharged, came back after 2 days with headache, confusion, seizure, and visual loss. Is this neuropsychiatric SLE? Her BP was high, 190/100. So this is what we call as PRESS. So PRESS does not need any immunosuppressions. We need to control her blood pressure, we need to control her seizure, then it will settle down because it is reversible. And PRESS, SLE is not the only cause for PRESS. There are so many other situations where PRESS can arise. ফিভাৰে আমাক ডেছ কৰে, শব্দটো মই নকওঁ, যেতিয়া এই পেচেণ্টজন ৰেফাৰ কৰে ফিভাৰৰ পেচেণ্ট মেডিচিনৰ মানে মোক সদায় কয়, সেই শব্দটোৱে কয়. So fever is always challenging in any field. In rheumatology also it is challenging. So this is a lady, she first came to us in 2021, January. She has polyarthritis 6 months and she had proximal muscle weakness. Not much, 4/5. She has puffiness around the eye. And she had lesions in her PIPs and MCPs, I will show that one. She has history of cough, Raynaud's, I was not sure. There is no edema, no dysphagia. Her proximal interphalangeal joints were swollen and tender, and rest of the investigations were normal. These are already investigations were done, anti-CCP was negative. Her SGOT, SGPT was elevated, and this was not coming from the liver, it was coming from the muscles. Her ANA was positive, but it was not significant. It was 1+, and dilution was 1:100. And this is the rash, typical rash of dermatomyositis. She has those erythematous rashes over the MCPs and PIPs. These are Gottron rashes. So this is diagnostic of dermatomyositis. So CPK and LD was normal, but other investigations for liver were normal. So that's why we thought that with that kind of rash, we are sure that this is dermatomyositis. She has history of cough. We did CT scan of the thorax, and that was showing early ILD. So all these clinical features fit into dermatomyositis. We did one EMG also. Neurologists also feel that EMG finding actually fits, though not typical of myositis, but it fits into myositis. So we treated her as dermatomyositis and ILD. So we started with prednisolone 1 milligram per kg per day. Plan was to taper it after 1 to 1.5 months. Because of early ILD, we started mycophenol methylphenidate and along with hydroxychloroquine. So she came after around 1 month. She has itching over the joints, otherwise other things are normal. Muscle power is also 5/5. And if we look at the SGPT, initially it was around 367 and 134. Now it has come down to 100 and 101. Muscle enzymes usually takes time to, clinically she has improved a lot. So we started tapering steroid. And in dermatomyositis, actually we are very slow in tapering steroids. Unlike we are more careful than in SLA. But she was lost to follow-up. So she came back in September 2023 with fever since July. And she has lots of arthralgias and myalgias. Her right knee is swollen and tender, and she also complains of dyspnea on exertion. She has generalized skin rash, but probably she is on steroids for a long time herself, and she has developed tinea versicolor. And outside, she has already received 3 doses of methylprednisolone. So her SGOT-SGPT is normal now, but her total count is high. She has creatinine is in the rising trend, and urine is showing active urine sediment with albumin 2+, and blood 2+. CT thorax was repeated outside. That was showing mild pericardial effusion, mild right-sided pleural effusion, and fibrosis in both the lungs. I have hidden the last investigation. Actually, diagnosis was actually done outside, should have been done outside actually. And I was able to guess this diagnosis in the OPD itself because I am regularly attending the CMEs and conferences of medicine. This is not rheumatology, this is pure medicine. So she was admitted twice. She was treated mostly with steroid pulses. So Ding sir presented fever in rheumatological disorders. But in the OPD actually, when the patient's main complaint is fever, mainly we think 3 things. One is SLA, one is vasculitis, and third thing is adult onset disease. All our diseases can have mild fever, but when main complaint is fever, we think of these diseases only. And in our disease, always first thing is to, even with these 3 diseases also, we need to exclude infection. So what that investigation I have hidden, blood culture was showing Staph aureus. So now what is the diagnosis? Straightforward, I went for tensiesophageal echo, and that was showing infective endocarditis. So she was having infective endocarditis. She has dermatomyositis, but along with that, she has developed infective endocarditis. So next, is probably 5 minutes left. This should be the last patient. So this is a journey of a SLE patient, how they behave in the long run. So she first came to us in 2013. She was a 19-year-old girl. She had minor organ SLE. She had fever, polyarthralgia, discoid rash, ANA was positive. So at that time, no major organ was involved. So by 2018, she is on prednisolone 5 milligram, then azathioprine 50 milligram, 100 milligram, and hydroxychloroquine. So she was okay for 5 years. And if we look at the different series and textbook, after 5 years, involvement of major organ in SLE actually comes down, chances comes down. But problem is, our patients, like say, they don't read the textbooks. So what happened in 2000? She started having proteinuria. Protein was a 3+ protein. So we advised her renal biopsy, but she declined. So we increased the dose of steroid, and we started mycophenolate mofetil. But after 8 months of mycophenolate, when to actually we sensed there is no clear-cut guideline, but we thought 8 months is enough time. So at this point, our proteinuria was continuing. At this point, we were able to do that renal biopsy, and that was showing class 4 and 5. Activity was 6, and she has chronicity. And chronicity, even 1, is actually a poor prognostic factor. So we stopped her mycophenolate, and we started endoxan bolus, and we followed the NIH protocol. And we started with a good dose, that is 1,000 milligram every month. So she received 6 doses of endoxan, but still there was no response. Her albuminuria persisting. So we, after 6 doses of endoxan, we started tacrolimus. Again, there was no response. So at this point, we thought that rituximab will be a better choice, but affordability was an issue. So we started combination therapy, tacrolimus and mycophenolate. So later on, she developed tremor with tacrolimus, so we changed that one to cyclosporine, and she was actually able to achieve complete remission with this combination therapy. But what happened in 2020? This was the corona time. That was in September. She came with fever with seal and rigor. And if we look at her dsDNA was elevated, her C3 is low, CRP is high. CRP in SLE actually, usually it is low, but in some cases of SLE, like if the patient has arthritis, And if the patient has serositis, because she has mild pericardial effusion also, so she has serositis. In these situations, even without infection, patient can have elevated CRP. So, and she has developed anemia, her ESR is raised, her total count is normal. So we almost thought that we should give her methylprednisolone. Whatever fever she is having, probably it is because of disease activity. But somehow we thought that there is something we are missing. So we evaluated like a fever of unknown origin. We did one CT scan, and that was showing miliary tuberculosis. So we treated her, and we continued cyclosporin. We stopped mycophenolate for the induction period. Then again, we restarted it. And if we look at, she came back 3-4 days back. She is now in complete remission. But I salute her. During all this period, she has completed her nursing study. She is now working under NRHM. She got married, and now they are planning pregnancy. So what to do now? So steroids, she is on 7.5 milligram. That should be okay with pregnancy, but if possible, we would like to come down to 5. 10 milligram is okay. Mycophenolate, we have stopped. So we have continued the cyclosporin. That is okay with pregnancy, but we have to stop that enalapril. But after, we cannot stop altogether. So after mycophenolate, we again have to review frequently. Then, if possible, if everything goes fine, then we will change that enalapril. Then probably she can plan pregnancy. So this is a 10 years journey. So 1 minute left. This is malignancy-like presentation, 9-year-old homeopathic doctor, presented with anorexia, generalized weakness, body ache, severe bone pain. He has mild muscle weakness, grade 2 clubbing. Investigation shows iron deficiency anemia. Then calcium, ionized calcium was low, alkaline phosphatase was very high. So basically, features of malabsorption, but there was no gut symptom. So ultimately, we did a duodenal biopsy and an IgA antimicrobial antibody. So it turned out to be celiac disease. So I think I will stop here because time is limited. Just last spot diagnosis. So this is a 70-year-old male presented with backache, arthralgia, myalgia, and feverish feeling for 1 year. He has scleritis, he has redness of the ear, and he has hearing loss. So I'll leave it here. So this picture actually depicts medicine and rheumatology in particular. So we work in a beautiful hospital, but there is always surprises. This is in the parking area, there was a leopard. So we have to be careful about the surrounding area in our patients. Thank you. Thank you for your patience here.
Thank you, Pradeepda. That was, as usual, a very concise, crisp, and a beautiful presentation. I'd like to call on the next speaker, Dr. Chiranjita Fukan Madam, and she is a professor of medicine in Guwahati Medical College, and we look forward to her talk.
Respected chairpersons, my teachers and distinguished delegates. I thank the organizing committee who has given me an opportunity to stand before you and deliver a talk on a minimal investigative approach in rheumatological disorders. There was a time when a clinical diagnosis of a patient was based on a very good history and a very good clinical examination. Currently, comprehensive physical examination has become a disappearing art. We tend to rely more on investigations than our clinical acumen. And in rheumatological disorders, let me tell you, lab diagnosis rarely make a diagnosis. Lab tests rarely make a diagnosis. This test most often help us to predict the disease activity, the prognosis, the end organ involvement, and the response to therapy. Improper test utilization in these disorders may lead to misdiagnosis, may lead to inappropriate therapy, and of course, unnecessary expenses on the part of the patient. I take this liberty to start my talk by using certain case virginities so that I can provide you with a practical and an evidence-based approach in the diagnosis of rheumatological disorders. So Osler had told us, listen to your patients. They are telling you the diagnosis. Coming to my first case, a 41-year-old woman, previously in good health, came to her physician with pain and swelling in her hands and early morning stiffness of about 2 hours. The duration of her symptoms were 6 weeks, and she denied any extra articular symptoms. On physical examination, there was synovitis in the right metacarpophalangeal joints, proximal interphalangeal joints of the left finger, middle finger, and the left wrist. The primary care physician was concerned that her symptoms could be due to rheumatoid arthritis. Now, would testing for rheumatoid factor and anti-citrullinated peptide antibody, which we know as anti-CCP, be useful for this patient? Rheumatoid factor, as we all know, is antibody directed against the Fc fragment of the IgG. And it is pertinent that many studies have shown us, and particularly this meta-analysis has shown us, that rheumatoid factor and anti-CCP have a sensitivity of similar, 68%, but the specificity of anti-CCP is much more higher, 95% compared to 85% with rheumatoid factor. And this rheumatoid factor can be found positive in many diseases apart from connective tissue disorders. Like Dr. Pradeep has just mentioned in one of his cases that rheumatoid factor A and ADs are positive in infections like hepatitis B, tuberculosis, and so on. And the caveat here is that in 5 to 25% of patients, we have a rheumatoid factor positive. So whenever we approach a patient with joint pain, which is not due to any injury or hypertrophy of the bones, with an early morning stiffness of more than 30 minutes, and the inflammatory markers like anti-CCP and CRP being elevated, we should consider it an inflammatory type of the problem. And the second question that we often identify is there a definite cause which could be the cause of this inflammatory arthritis? You know, the pattern of joint involvement could point to a diagnosis of whether the patient is suffering from gout, arthritis, SLE, or maybe any other. Now, if the arthritis is undifferentiated, the next question, confronting us clinicians is it going to get better by itself, remit, or will it be persistent? Now, the ACR-Euler criteria 2010 laid down certain risk factors which denote persistence of the disease. And these are the number of joints that are involved, the duration of symptoms, and the elevated acute phase reactions. If the duration of symptom is more than 6 weeks and the acute phase reactants are high and the number of joint involvements with especially the smaller joints are high, then we say that it's a persistent disease and the patient may go on to develop full-blown rheumatoid arthritis and needs immediate treatment, because studies have again demonstrated the earlier the treatment, better it is to prevent the complications. One thing important is that the rheumatoid factor, once detected positive, need not be tested again and again, because it does not give any indication of the prognosis. However, the presence of anti-CCP and rheumatoid factor in a patient points to the fact that these patients have a more chance of having erosive diseases in future. So we often have patients who we sometimes do go for panels like arthritis panel, where we are unnecessarily getting results which put us in a dilemma. So suppose we have a patient who is RA positive, anti-CCP positive, what do we do? He's asymptomatic. Well, studies have demonstrated that RAF and anti-CCP may persist many years before the clinical diagnosis of rheumatoid arthritis, and the risk of developing arthritis depend on if these patients have a positive family history or they have a co-presence of anti-CCP. Currently, there is no strategy which is given to prevent the development of rheumatoid arthritis. So we go back to our patient who came to us with joint pain, and on investigations, there were normal blood counts, the amino transferase levels were normal, and creatinine was also normal. ESR and CRP high, giving the acute phase reactants were high. Testing was negative for rheumatoid factor and anti-CCP, and the parvovirus serology was also done because parvovirus present with symmetrical arthritis, so akin to rheumatoid arthritis. The patient was given corticosteroid therapy. She responded briefly. She came back with persistence and increase in symptoms. Diagnosis seronegative arthritis. Methotrexate was started. Patient became better. Coming to a second case, a 37-year-old woman presented to her primary care physician with complaints of tiredness. She had a family history of SLE in her sister and maternal end, and she was worried that she also could be suffering from SLE. Now the question she came to us is she wanted to be tested for SLE. Now, would testing for anti-nuclear antibody be reasonable? Well, there are many conditions which are associated with a positive ANA. For SLE, we find that 95 to 100% patients could be positive with an ANA, but in systemic sclerosis, it is only 60 to 80%. And for the diagnosis of systemic sclerosis, clinical criteria is enough. ANA positivity or negativity doesn't matter much. However, there are 3 diseases for which ANA positivity is a must and used in diagnostic criteria. It is drug-induced SLE, autoimmune hepatic diseases, and MCTT. There are also other diseases like infections, ITP, thyroid diseases, in which ANA could be positive but is not important for diagnosis. So how do we interpret this ANA? I won't go into this much. Pradeep has already touched into the topic, but I would like to stress that the clinical scenario is a must. If we have symptoms suggestive of connective tissue disease, it is only then it is pertinent to look for whether the ANA is positive or not. And yes, the titer matters, because the higher the titer, higher chances that the ANA positivity is true positivity. In fact, this is important, the titer, because there has been studies which have shown anti-nuclear antibodies in healthy individuals. In a titer of 1:40, 32% of normal healthy individuals can be positive. In a titer of 1:160, 5% could be positive. So a positive anti-nuclear antibody result does not always mean lupus. Third is we look at the staining or the immunofluorescence pattern, which is done in the ENA panel, and which, if we suspect that yes, this patient could be having symptoms with of inflammatory myositis, for example, then we specifically look for antijo. If we think he could be having scleroderma and we want to know the prognosis, then we look for antitopomerase isobody. So it is though theoretically a reflux, which we often write in our prescriptions after getting an ANA positivity, sounds so nice and so good, but evidence has shown that it can prove erroneous. It can prove, because of laboratory errors, it can prove costly to the patients. So based on the symptom, as a dry eyes, dry mouth, look for Sjogren's, anti-Ro, anti-La. So we should try to be more specific in our ENA panels instead of going for reflux studies. Studies from the community, studies from the hospital has just demonstrated that 90% of patients which are referred from community to a specialized rheumatology center, they have, with ANA positivity, was not detected with any connective tissue diseases. So the frequently asked questions is that, if ANA is negative, should the test be repeated or should other tests be done? Well, ANA done on HEP2 cells is very sensitive. So once negative, we do not need to repeat it. But if the clinical course changes based on the discretion of the physician, ANA could be repeated later on. Second, if the clinician suspects SLE, what tests confirm the diagnosis? Say in a patient with SLE, if you need to confirm your diagnosis, anti-dsDNA, which is 100% positive in patients of SLE. Smith antibodies, sensitivity very low, 30 to 60, but it is solely present in SLE and not found in LD individuals. Then if the diagnosis of SLE, after the diagnosis of SLE is made, what should we do to monitor disease? So to monitor the disease, we should look for the titers in the anti-dsDNA, which will show us if the patient is in flare or not. So we have finished with this. So back to our patient. Our patient denies arthralgia, no extra-articular symptoms, findings on physical examination were normal, and her blood counts were also normal. So she's reassured that her tiredness is not due to lupus. She insists on getting an ANA test. THS is elevated. Subsequent testing shows low free thyroxine levels and positive peroxidase levels, antibody levels. ANA was positive in a titer of 1:80. It was negative for dsDNA and ENA. Doctor explained to her that your positive ANA is most likely related to your autoimmune thyroid status, and she's referred to an endocrinologist. Coming to the third case, a 24-year-old woman presented to the emergency with unprovoked deep vein thrombosis, which was confirmed on ultrasonography. Her platelet counts was 84 into 10 to the power 9. Baseline APTT was prolonged. Rest of the test was pregnant. She had never been pregnant in the past. Should this patient be treated for antiphospholipid antibodies? Well, the consensus is that antiphospholipid antibodies should be persistently positive on 2 occasions, separate occasions, 12 weeks apart to label this as an antiphospholipid syndrome, and antiphospholipid antibodies are present in 1 to 5% of apparently healthy people. So this chart shows the indications for antiphospholipid antibodies, and when we came back to the patient, our patient's anticardiolipin antibody was negative. However, lupus and beta-2 IgG antibodies were positive. There was no clinical history or laboratory findings suggesting lupus. She started on warfarin. However, after 3 months, warfarin is stopped for several days. She is retested for all the 3 antiphospholipid syndromes. Her beta-2 glycoprotein and lupus was again positive. So the diagnosis was that of a primary antiphospholipid syndrome. She was advised to continue anticoagulant indefinitely. ANCAs should only be requested if the preclinical test probability of ANCA-associated vasculitis is very high. And the international consensus has revealed that if a person has this clinical indications of pulmonary hemorrhage, I've got 2 minutes, no? Okay. Cutaneous vasculitis, glomerulonephritis, scleritis, sinusitis, retroorbital mass, then if we do an ANCA, we are the international body is very sure that we will have an ANCA status positive. So ANCA is done with immunofluorescence. If it is positive, it is tested with 3rd generation ELISA for antiproteinase antibodies and MPO, myeloperoxidase antibodies. And different studies has demonstrated that patients with GPA may not be positive for ANCA or for PR3 and MPO antibodies also. So biopsy continues to be the gold standard for the diagnosis of ANCA-associated vasculitis. Uric acid, we know, acute gout patient may not have a very high uric acid level, and asymptomatic hyperuricemia need not be treated. Diagnosis of acute gout can only be made when we can demonstrate the presence of urate crystals under polarized light microscope. Coming to HLA-B27, any patient with backache, we tend to give this. Why? Actually, no. A young person less than 45 years of age coming with inflammatory backache in whom we suspect spondyloarthropathy, only those patients should be advised. And if the patient has got peripheral arthritis, enthesitis, dactylitis, and uveitis associated, yes, we can prescribe for a HLA-B27. However, the gold standard for assessing patients with spondyloarthropathy or those who have inflammatory backache continues to be the radiography of the sacroiliac joint, which if negative is to be substantiated with an MRI, which can show us bone marrow edema. So the key point here is that HLA-B27 is useful to make a diagnosis of axial spondyloarthropathy in the absence of imaging features and could be requested in patients with 2 or more features of spondyloarthropathy. So to sum up, the basic ground rules of obtaining a detailed history and performing a complete physical examination still remains the essential aspects of appropriate patient evaluation. And to conclude, we should remember that in the end, there is no substitute for common sense, good common sense, and clinical judgment, which should guide further investigations in the rheumatological disorders. Thank you.
Very nice. And Chiranjita, as suspected, you have covered very nicely and you have sent a beautiful message to the House. Now, the third speaker was supposed to be our Anu Burman sir, and sir has already delivered yesterday. Sir, would you like to repeat again today? Okay, sir. There. So at least we will have some comments also. So I think we're gonna a few minutes time. We can make this very important and nice discussion and nice talk, and so many queries and comments must be there. So can we have some comments and questions? Acha, my co-chairperson is going to ask. Let her ask first, please.
Pradeep, may I request you to please come up to the dais? My comment will be amalgamating both of your talks, madam, and Pradeep Sharma sir. When we are talking about diagnosis in connective tissue disorders, I think Pradeep will agree that in adults and in children is quite different. In adults, like you have said, we are supposed to see the prototype, the typical manifestation, and we hit on the diagnosis. If it is symmetrical polyarthritis, PIP joints, middle-aged women with early morning stiffness, we don't go for other panels. We go for RF and anti-CCB. In case of children, but if they come with suspected symptoms of GIA, then we do not hit on the diagnosis. We exclude the GIA. We have to exclude malignancies. And then, madam, for yours, like when you said when ANA is negative SLE, we rule out, I would just like to comment that in HEP2 cells, yes, because it cannot detect certain antibodies like anti-Ro and anti-Jo. But nowadays they are bringing a new one, HEP2000, Pradeep, if I'm not mistaken, please.
Actually, if HEP2 cell ANA is negative, that partially rules out SLE. Provided there is only one condition, which we call as prozone phenomenon. When that antibody titer is too high, then sometimes it can be missed. So sometimes actually you need to dilute the serum, patient's serum first, then we need to do that ANA. So if clinical suspicion is very high, if clinical features are too much in those patients, it is not like some arthralgias and fever, patient will have very high titer antibody, it is not like that. If the clinical features are too much, if still ANA is negative, then that patients actually need dilution of the serum before testing. Otherwise, nowadays, because ROLA antibody has actually are put in those slides. So yeah, fortified with ROLA, so that's why, yeah, have to, yeah. So those are fortified. So that's why previously it was negative. If ROLA is positive, ANA can be negative. Nowadays, as those are fortified usually, then ANA negative becomes very unlikely.
Thank you, Dr. Bhavi. Burman, sir.
Thank you. Thank you, Chairman, for allowing us to put a question. My first thing is that I must congratulate both the speakers for a brilliant presentation. Pradeep and Chiranjita, they have done justice to their talk. And then my question is again that whenever there is a controversy about diagnosing a connectivity disorders, then always a lupus isn't blamed. Right? Always try to whether we are dealing with a lupus or not. Because how comfortable you are doing in an ANA test, how comfortable you are with that laboratory, right? All these things will come. Because many times we have to repeat the ANA test. In our situation, from practical experience, I'm telling you, sometimes we have from clinical perspective, I'm sure that I am dealing with a lupus patient, but ANA is negative. Without ANA negative, it's very difficult to diagnose sometimes. But if you do a biopsy, in a biopsy renal, when in IgG and C3 is deposited, you can diagnose, then you are almost sure that you are dealing with a lupus. So in that way, that could be whether it's ANA negative lupus or not, I can't tell exactly right moment. But in our diagnosis, it's tissue diagnosis. And tissue diagnosis will tell you exact, right? This is another important thing. And second important aspect in such patient, in lupus patient, when they are resistant type of lupus and having some behavioral, some bizarre type of presentation, proliferative, then we suspect whether I'm dealing with a TMA-like presentations. So this is also important, but when most of the time we do AFLA test, when AFLA positive, negative doesn't matter. When you have some strong clinical sense of having a TMA or like a presentation, Is there any role of ADMT 13 scoring? Because there has come, but I don't know whether this is available or not. ADMTS code 13, that's code. Because they say that you should do and start scoring. If the score is less than 10%, that means you are 100% you are dealing with a TTP. Because when you diagnose it is a TTP case, like in TMA, your line of treatment is different. But you have to treat that appropriately in a very appropriate time, like in plasma exchange or plasmapheresis, because it is also life-threatening. So those things I think should be monitored. Although I am talking about the common investigation, but these are, although it's not a very not a common investigation, very expensive, but sometimes maybe a life-saving for the patient. Just I would my comment on that, because I said no, SLE diagnosis sometimes very easy for us and sometimes very difficult.
Thank you, sir. Very illuminating your comment. We appreciate that. So before that, Dr. Pradeep, I'd like to have just a comment on Pradeep case, if the Sangeet Datta sir is also here. So Pradeep, you have mentioned one of the case that liver enzyme SGOT, SGPT was raised, so you're contributing to the rheumatology cause. To my understanding, SGOT can be of different sources, not SGPT. So subsequently, once you've seen that SGPT also arise, so definitely we're going to look for other than the musculoskeletal system. And that's what, at that point, that may be also one of the clue, probably we have ultimately come to the other diagnosis.
Actually, yeah. That part is most important part in that patient initially was that skill lesions in the PIPs and MCPs. So those are diagnostic. Autoimmune liver disease, yes, possible, but ILD with autoimmune liver disease won't go. So that's why the initial diagnosis was dermatomyositis. She didn't have infective endocarditis at that point, and she was not complaining of fever. So infective endocarditis diagnosis was done after 2 years from the initial diagnosis.
Thank you. And also, one of the cases we have shown, the Pradeep, that fever will chills patient later. So my previous, there is Dr. Prasanta Dihinges also spoke about the PUO, the rheumatoid disease. I think once, I think if you take the rheumatology background, if somebody has the fever with chills, so probably you are something dealing with autoimmune, or if you are not dealing with the autoimmune disease. So I just noted down. And my question is by Pradeep. One of the cases you have started mycophenol mofetil first, then the endoxin. Later you have shifted to endoxins. So why not the endoxin first, just as a common physician asking?
Yeah, actually, the response rate for endoxin and mycophenol are same. So first, when it is young lady, future pregnancies, issues are there, so usually we prefer mycophenol over endoxin. But we give the choices, whether patient can afford or not. So if the patient can afford, and we discuss all these things before starting. So both are same response-wise, but future pregnancy issues, mycophenol scores.
Very nice. That point is very important. One should consider that point. Regarding Dr. Chiranjita, you have mentioned that in the diagnostic panel, the ANA should be positive in case of AIH, autoimmune hepatitis. So to my understanding, I think to diagnose autoimmune hepatitis, in the probable diagnostic criteria are there. So ANA is ideally required, but is not a must. So other factors like anti-SM antibody, anti-antibody, and the international guideline on autoimmune hepatitis guideline, if you suit that, so ANA sometimes may be negative in operative. Your comment on that?
Nonida, the consensus is that if we suspect a case of autoimmune hepatitis, first test we should go for is a ANA, because ANA is 100% positive in patients of autoimmune hepatitis. It is only when a patient is positive for ANA, we go for the rest of the antibodies to see which antibody, in his case with asthma, LKM, what is positive or not.
Any comments or questions from the house? Madam, you.
Okay, thank you. Just one question, short question.
Good morning, sir and ma'am. Just a small question. We notice many people, like younger population, having undifferentiated CTDs. We may have ANA positive, but and they'll have symptoms, but reflex panel may not give us anything specific. In such a case, how should our approach be to treat and follow up such cases? Because they may differentiate, they may not differentiate. So in such cases, how do we approach the diagnosis and the treatment?
You would like to?
In those patients who are ANA positive, and if the clinical diagnosis points to the fact that the person has features related to connective tissue diseases, you can have it tested in another lab which you think will give you a good result. And next, otherwise just follow up the patient as such and then repeat if necessary. But generally, like Pradeep has said, with the HAP2 cells that are being used for the immunofluorescent technique nowadays, it is very unlikely that ANA will be negative if the patient doesn't, ANA will be negative if the ANA is truly negative. And if you think that yes, the patient has clinical features, then I think you should repeat it once again.
Okay, thank you very much. Thank you, both the speakers, for your excellent deliberation. And thank you, organizers, for giving this opportunity to share the session. And thank you for the comments and questions from the audience. Okay, I would like to conclude the session here.
Thank you so much, respected speakers and chairpersons. May I please invite you to pose for a photograph? I think it would be pertinent to include Burman sir also here, though sir had given the talk yesterday. Sir, if you could please come up. Sir, talk was preponed, but yes, sir. Yeah. Thank you so much. We now will have the API oration, but before that, there is an obituary. We all know our very much beloved, one of the most active members of API, Dr. Deepak Chanchal Barbara, who passed away recently, untimely. We would like to have a minute of condolence. Would like to have a minute of silence for the departed soul. May I request you all to please get up for a minute and pray to the Almighty for his peace. Thank you. Now for further conduction of the API oration, I would like to hand over the proceedings to the Secretary, API Dibrugarh Branch, Dr. Anupam Dutta.
Ladies and gentlemen, and esteemed members of API Assam and the honored guest, it is a great pleasure that we gather here today to celebrate and honor a distinguished individual who has made an incredible mark in the field of API in Assam. The API oration is sponsored by API Dibrugarh Branch and is a testament of the unwavering commitment and exceptional contribution of a senior API member who has dedicated their life in this profession. For this oration, prestigious oration, I would like to request our chairpersons, Dr. P.C. Bhattacharya sir, Dr. Bhavani Prasad Chakraborty sir, Dr. Pramod Das sir, Dr. Prashanta Bhattacharya sir, Dr. N.N. Deka sir. Sir, kindly take the seat as the chairpersons. I would request our chairpersons to introduce our distinguished speaker for the oration, API oration, and I would also request President of API Dibrugarh branch, Professor Prakhanto Dihingia sir. Sir, kindly come to the dais.
I would like to, good morning. I would like to invite the orator, Dr. Kartik Kumar Barua, for his oration. To introduce him, he has the qualification of MBBS from AMCH Dibrugarh University, completed in 1971. MD Medicine from that college, Dibrugarh University, completed in 1977. Experience worked in various government hospitals in different capacity of Assam from 1977 to 2009, and retired as Additional Chief Medical and Health Officer from the Office of the Joint Director of the Health Services, Jorhat, Assam. Currently working as Senior Consultant Physician with an experience in the field of diabetes and preventive cardiology at Sanjeevani Hospital, Jorhat. Board members attended various board meetings for many Indian and multinational pharmaceutical organizations, live membership, API, IMA, Research Body of Study of Diabetes of India, conference participation, participated in district level management workshop in for RCS program in IMIC, Management Kolkata, Joka, Calcutta 2002, attended as a chairperson on 44th National Dyslipidemia Summit 2015, attended various health camps during government services, regular participant in national conference like APICON, RSSJ, and CSI, attending all district and state level conference regularly, actively involved in different activities of Association of Physicians of India in both state and national level as faculty member, advisor for many years in API Jorhat branch till date, attended as faculty member in CSI, attending regularly CAD conference, honored with Fellowship of Indian College of Physicians, FICP at APICON 2023 at Ahmedabad. With this introduction, I would like to request Dr. Barua sir for Dr. Anupam Doctor to introduce him.
Before, as this is a very prestigious oration, I would also request Ornima Madam. Madam, kindly take the chairs. And I would request our DME sir, Anupam sir, kindly take the chair as a chairperson in this session, sir. Now I would request our President, API Dibrugarh branch, Professor Prakhanto Dihingia sir, to felicitate our Kartik Barua sir with the Path Selling Sador and Khadi jacket. I would request all the chairpersons to hand over the memento to sir. Sir. Now, our President, Professor Dihingia sir, will read the citation.
আজি আমাৰ খুব সন্মানীয় যেটো অসম আমি API অৰেশ্যন বুলি কওঁ আজি এটো আমি আমাৰ সন্মানীয় চিকিৎসক যোৰহাটৰ ডক্টৰ বৰুৱা ছাৰক দিবৰ কাৰণে আমি এইবাৰ আমাৰ কমিটিয়ে সিদ্ধান্ত লৈছে তেখেত খুব অভিজ্ঞ আৰু তেখেত যথেষ্ট অগ্ৰজ গতিকে তেখেতক আমি এখন আমাৰ সাইটেশনৰ দ্বাৰা সম্বোধন কৰিম সেই বিশিষ্ট চিকিৎসক শ্ৰদ্ধেয় ডাক্তৰ কাৰ্তিক কুমাৰ বৰুৱা দেৱলৈ আমাৰ সশ্ৰদ্ধ নিবেদন অখতমা সদ গময় তমসুমা জ্যোতি গময় মৃত্যুমা অমৃতং গময় ওম শান্তি শান্তি ওম শান্তি যোৱা কেইবাটাও দশক জুৰি চিকিৎসা সেৱাৰ ক্ষেত্ৰত অসম তথা উত্তৰ পূৰ্বাঞ্চলত আপুনি যি অৰিহণা আগবঢ়ালে সি অনস্বীকাৰ্য বৈজ্ঞানিক দৃষ্টিভংগী আৰু মানৱীয়তাৰ সুসমাহাৰে জনতাৰ সেৱাত ব্ৰতী আপোনাৰ সুদীৰ্ঘ সাধনাক আজি আমি কৃতজ্ঞতাৰে সোঁৱৰিছোঁ চিকিৎসা বিজ্ঞানৰ এজন মহান চিকিৎসক হিচাপে আপোনাৰ অৱদান অতুলনীয় ভাৰতীয় কায় চিকিৎসা সংস্থাৰ অসম শাখাৰ জন্ম লগ্নৰে পৰা আজি পৰ্যন্ত আপুনি যিদৰে গুৰি ধৰি আহিছে তাৰ বাবে আমি আপোনাৰ ওচৰত চিৰকৃতজ্ঞ অনাগত দিনবোৰত আপোনাৰ আৰু আপোনাৰ পৰিয়ালৰ সুস্বাস্থ্য তথা অধিক কৰ্মময় জীৱন কামনা কৰিলোঁ ইতি অনুপম দত্ত সম্পাদক প্ৰশান্ত দিহিঙীয়া সভাপতি ডিব্ৰুগড় কায় চিকিৎসা বিভাগৰ সভাপতি আৰু সম্পাদক মই এইখন মানপত্ৰ বৰুৱা ছাৰক অৰ্পণ কৰিম ইয়াৰ পিছতে আমাৰ ডক্টৰ অনুপম দত্তই আমাৰ এইখন যিখন সম্বৰ্ধনা পত্ৰ তেখেতে পাঠ কৰিব ছাৰ
Association of Physicians of India Oration, API Dibrugarh branch. This is to certify that Association of Physicians of India Oration is delivered by Dr. Kartik Kumar Borua at APICON Assam held at Tezpur on 17th of December 2023. Your contribution to the medical science and services in Assam and the Northeast over the past several decades is undeniable. Today, we remember you with gratitude, your long service to the poor with a combination of scientific perspective and humanity. Your contribution as a great doctor of medical science is incomparable. We are eternally grateful to you for the leadership you have given to the Association of Physicians of India, Assam State Chapter, since its inception. We wish you and your family good health and a more productive life in the coming days. Professor Prakhanto Dihingia, Chairperson, Dr. Anupam Datta, Honorary Secretary, Association of Physicians of India, Dibrugarh Branch, Dibrugarh, Assam. So the stage is all yours.
respected chairpersons.
President, API oration will be started by Dr. Kartik Kumar Borua sir, and I hereby invite him to start his deliberation.
Thank you so much. Respected chairpersons, esteemed members of API, distinguished guests, and my dear doctor friends. Today, I stand in front of you with a profound gratitude in my heart for giving me this opportunity to give this oration, prestigious oration of API. First and foremost, I would like to extend my heartfelt thanks to the organization, API Chairperson, Assam Chapter, General Secretary API, Assam Chapter, and API Dibrugarh Branch Headquarters, as well as API Tezpur Branch for this felicitation ceremony. I would like to acknowledge the unwavering support of my colleague, Dr. Deepak Sharma, Dr. Uttam Nath, who has supported me in preparing this oration, that is, the resistant hypertension, difficult to treat hypertension. It is because of the collaboration and shared knowledge that we can increase or we can elevate the level of medical practices. I would like to thank my family, my wife, who has given me a great support during my lifetime in the field of medical science, and I am grateful for her in my difficult time also. Now, I would like to extend my deepest gratitude towards my all patients whom they taught me the lessons of compassion, empathy, and the true meaning of healing. Lastly, I would like to say that being a life member for the last 40 years, this platform has given me a lot of scope to update myself in the field of medicines, for which I remain ever grateful to it. So with these words, I would like to now present my orations. My talk is resistant hypertension, difficult to treat hypertension. Before I talk about resistant hypertension, I would like to show the incidence of hypertension. As you have seen in the slide, this is hypertension in India. As a whole, it is a global phenomenon. We can find that the incidence in hypertension in India, it is urban people are mostly afflicted than the rural area. But nowadays, the incidence in rural area is also increasing day by day. So that is a matter of great concern, why it is increasing. Maybe because of various reasons, and I think because of more modernization and lifestyle changes that helps to develop more, increase the incidence of hypertension. And the sex-wise, more or less equal in man and female, as well as in the global scenario also. Now the definition, according to 2023 European and current international guidelines, hypertension is defined based on repeated office systolic blood pressure more or equal to 140 millimeter of mercury, and diastolic more or equal to 90 millimeter of mercury. Now, this is a classification. I don't want to go into details. What are the class 1 hypertension, class 2, class 3? Next, I would like to talk to my talk, and that is your resistant hypertension. Hypertension is defined as a resistance to treatment when appropriate lifestyle measures and treatment with optimal or best tolerated doses of 3 or more drugs like thiazides or thiazide-like diuretics and RAS blocker and calcium channel blockers fail to lower the office blood pressure below 140 by 90 millimeter of mercury. And this is a pyramid showing the same thing: blood pressure not on target, 3 drugs used, 1 in the diuretic at optimal doses. Prevalence of hypertension depending on number of factors, but I would like to show this slide where you can see in general population is low. It's low below 10%. In specialized clinics, 15%, in clinical trials, 30%. And these are all strong associate conditions where there is a development of resistant hypertension, like type 2 diabetes mellitus, CKD, obstructive sleep apnea syndrome, as well as left ventricular hypertrophy. And also some contributing factors like excessive alcohol consumption, high sodium intake, which is very, very important, advanced hypertension-mediated organ damage and atherosclerotic disease, older age, male sex, like low income group, depression, and high blood pressure values at hypertension diagnosis. This is also important. And a 10-year cardiovascular risk score more than 20%. Other causes are like poor adherence to treatment plan, intake of drug that raises blood pressure. We should try to find out what are the drugs that raises blood pressure, lack of lifestyle adherence, and subclinical volume load, overload, inadequate use of diuretics, progressive renal insufficiency, unsuspected secondary causes. Causes of secondary hypertension. This is a pie chart which is showing, you may find that 3/4 are being occupied by this medication, which causes about 58%, non-adherence in 16%. That medication may be inadequate doses, inappropriate combination, etc., or suboptimal doses, and non-adherence is a major factor in the cause of resistant hypertension. So there are a lot of causes of secondary hypertension. You can find out from these slides: obstructive sleep apnea, primary aldosteronism, renal artery stenosis, renal parenchymal disease, the renal causes, endocrine causes, and other causes are also there. But as a whole, common causes of secondary hypertension is primary aldosteronism, pheochromocytoma, Cushing syndrome, RAS, and renal diseases are responsible. Now let us come to the pathophysiology of resistant hypertension. The pathophysiology of true resistant hypertension involves an interplay between the multiple neurohormonal factors, increased sympathetic activity. These factors contribute to volume and sodium overload, increase in peripheral vascular resistance, arterial stiffness, and more advanced hypertension-mediated organ damage, including cardiorenal damage. Patients with resistant hypertension are at a higher risk of hypertension-mediated organ damage, CKD, and premature cardiovascular events. Now, this is the diagrammatic representation of how the brain is involved. You will find the RAS and obstructive sleep apnea, which leads to resistant hypertension, abnormal renal function, then high aldosterone level. All these are contributing factors. Now, let us come to the diagnostic workup. The diagnostic workup, first you have to rule out the pseudo-resistant hypertension and characterize the patient's clinical status. By history, physical examination, and laboratory and imaging analysis of the assessment of risk factors and HMOD. Now, exclusion of pseudo-resistant hypertension requires, number one is demonstration of an elevated ambulatory blood pressure monitoring. The next, exclusion of an origin of the blood pressure elevation from inaccurate blood pressure measurements, which is very common in our clinic scenario. The exclusion of a secondary cause of hypertension needs to be done very meticulously. Then exclusion of poor adherence to the prescribed treatment regimen. This is also very important because most of the scenario you will find that prescribed treatment is not being followed by the patient. This is a picture showing how to distinguish between white coat hypertension and pseudo hypertension by home blood pressure monitoring where there is no facilities or ambulatory blood pressure 24 hours monitoring. And this is resistance hypertension. Do not trust office blood pressure only. It is only by the ambulatory blood pressure monitoring where we can find out the resistant hypertension. And this is another tool, ABPM tool, which is showing how you can come to a conclusion by exclusion the other factors and come to a conclusion that you are dealing with a case of resistant hypertension. Now, ambulatory blood pressure monitoring is a very important tool, not only for diagnosis, but also for treatment and follow-up. Poor adherence to antihypertensive. Poor adherence to antihypertensive drug treatment is common in resistant hypertension. Careful inquiry and about the patient's medical habits, if necessary, with the help of patient's relative is the first step. Then history should include accurate information on use of drugs. What are the substances or drugs are being used, potentially interfering with blood pressure control, either by impairing the efficacy of antihypertensive drugs or by increasing blood pressure. We should try to find out those causes. Then some other factors are responsible also for medications like to contribute the hypertension like corticosteroids, NSAID, antidepressants, cyclosporine, nasal decongestant, which is commonly being used, and they produces this one. Now, optimizing lifestyle changes and ongoing drug therapy. Effective treatment of resistant hypertension should combine number one, lifestyle changes, particularly reduction of sodium. We should emphasize on that particular point, and alcohol intake, implementation of regular physical activity in weight loss in overweight or obese patients. Discontinuation of the interfering substances, rationalization of current treatment, and sequential addition of antihypertensive drugs to the existing triple therapy. Replacing current drugs with a more rational and possibly simpler treatment regimen is based on use of combination therapies that are appropriate to a patient's age, ethnicity, compelling indications for certain drug classes, comorbidities, and risk of drug-drug interactions. Drugs should be used at the maximal tolerated doses, and single pill combination should be preferred when available to reduce the pill burden and improve adherence to treatment. This is also very important if we can give the 3 drugs in a single pill where the compliance of the patient's compliance will improve and they will like it to take only in a single pill. So this is a good conception. And reducing sodium intake is less than 2 grams and increasing the intensity of the diuretic therapy, particularly in older patients and patients suffering from CKD. Here you can find that if eGFR is more than 30 milliliter per minute, blood pressure control may be improved by increasing the dose of existing thiazide diuretics or by switching to a possibly more potent and longer acting thiazide like indapamide or chlorothalidone. And if eGFR is less than 30, in that case we should switch over to a loop diuretic. Preferably furosemide, bumetanide or torsemide should replace thiazide group of drugs. Careful, while using these drugs, careful monitoring of kidney function, serum electrolytes levels, and fluid status is required to detect whether the patient has developed dehydration or hypokalemia, hyponatremia, hypovolemia, or worsening of kidney function. After optimizing the ongoing therapy, a stepwise addition of antihypertensive drug should be considered if BP is not at goal. The fourth and subsequent lines of antihypertensive therapy. In patients with resistant hypertension, the fourth line treatment should include MRA. It's a very important spironolactone. Now, two trials, they have showed Pathway 2 trial as well as TopCat trial has shown the beneficial effects of spironolactone. Closely monitor plasma potassium and eGFR after treatment initiation, and depending on the individual risk and the CKD stage, at least annually or 3 to 6 months interval thereafter. Now, this pathway trial, it is showing very clearly a message has been given that among patients with resistant hypertension, spironolactone was the first most effective add-on agent for improved blood pressure control. Other steroidal MRA like eplerenone can be used alternatively to lower blood pressure, but it is less potent than spironolactone, which we are using frequently in our day-to-day practice. Alternative drugs like amiloride can be used at a higher doses, but normally it is available in 5 milligram tablet, but here the dose is recommended is 10 to 20 milligram, which was as effective as spironolactone 25 to 50 milligram per day in reducing blood pressure in open label extension period of the Pathway 2 trial. But there will be amiloride, there will be pill burden will be more. Future alternatives to spironolactone, there are lots of renones such as finerenone are recommended for the treatment of resistant hypertension. Finally, the use of selective aldosterone synthesis inhibitors such as baxdrostat has been shown to be effectively lower the blood pressure in patients with resistant hypertension in phase 2 trial. When spironolactone and other MRAs are not tolerated or contraindicated, like in CKD stage 4, where the eGFR is less than 30, we can go for these three drugs, bisoprolol, doxorubicin, clonidine, which I think most of our colleagues are using. Depending on approval and availability, the dual endothelin antagonist aprocitenib may be used. Direct vasodilators such as hydralazine or minoxidil should be used posthumously, that means cautiously, because they may cause severe fluid retention and reflex sympathetic activities which may lead to tachycardia. Additional treatment option for frequent comorbidities. If the patient is having obstructive sleep apnea, we can reduce by giving CPAP, which will mild to moderate, they will benefit it. Then in obese patients with type 2 diabetes mellitus, we can go for GLP-1 receptor agonist, which reduces blood pressure along with reducing the blood glucose level. Bariatric surgery can also lower blood pressure, cardiovascular risk factors, and risk of cardiovascular events in severely obese patients, and may thus reduce the burden of antihypertensive medications when these patients have resistant hypertension. In patients for treatment with SGLT2 inhibitor, their use may add a moderate blood pressure lowering effect to the background of antihypertensive drugs for resistant hypertension patients. And we are already using this SGLT2, different group of SGLT2 inhibitors in the treatment of diabetes. Finally, the sacubitril valsartan, which is a combination, reduced blood pressure, is upcoming in patients with resistant hypertension, despite treatment with at least 4 antihypertensive drugs, including MRA. So we can use this sacubitril valsartan, which reduces resistant hypertension. Non-pharmacological approaches are there, like baroreceptor activation therapy, renal denervations, have been tried with varying results. This renal artery denervations. Now this slide I would like to focus. This is the recommendation, strong recommendation, resistance hypertension. If the blood pressure, it is the recommended that hypertension is defined as the true resistant hypertension when systolic blood pressure is more or equal to 140 millimeter mercury or diastolic blood pressure more or equal to 90 millimeter mercury, provided maximum recommended and tolerated doses of 3 drug combination comprising a RAS blocker, either AC or ARB, a calcium channel blocker, and a thiazide or thiazide-like diuretics were used. Adequate blood pressure control has been confirmed by ambulatory blood pressure monitoring. Various causes of pseudo-resistant hypertension and especially poor medications adherence and secondary hypertension have been excluded. And this can be done by doing ambulatory blood pressure monitoring, or if it is not feasible, in that case we can go for home blood pressure monitoring. A dedicated tertiary blood pressure clinic can be useful to perform the necessary diagnostic steps, optimize the multi-drug treatment regimen, reduce the likelihood of drug-related adverse effects, and increase adherence to treatment. The take-home message: resistance hypertension is a common problem in clinical practice, especially secondary and tertiary care. Ambulatory blood pressure monitoring mandatory for diagnosis and follow-up. This is very important. We should follow it out. Secondary causes must be excluded. Then we should ensure 3A. One is accuracy, adherence, advocacy. Then stepwise algorithm is advised for drug therapy like diuretics, calcium channel blockers, AC1 inhibitors, or ARB combination advisable. Or 1 blood pressure lowering drugs at night has been recommended. Mineralocorticoid receptor antagonists, spironolactone, and diuretics are important choice. To sum up that slide which I shown earlier, this slide has been recommended recently in 2023 in European Hypertension Society, and I think we should follow this chart nicely, because it is the recommendation as recommended as class 1 group of recommendation. That is why I like to request that we should follow this one. Thank you.
Thank you, Guru sir, for excellent oration of a subject which is very common for all physicians that we face, and make it very easy for everyone. As this is an oration, so no question will be allowed. And I here again really thank you for your presence.
Thank you.
I hereby conclude the session.
Thank you, sir.
Thank you all dignitaries. With this, we come to the end of the API oration. Now I again hand over the mic to the organizers. So I would request Dr. Piyush to continue with the scientific program further. Thank you very much.
Thank you, Dr. Anupam. So thank you all for your cooperation in the oration. Now that the oration is over, we have the next hot item on the menu. I'm sure you all are waiting for this next agenda, the next item on the agenda, which is the medical debate. Now, a lot of buzz has already been generated around this medical debate. I would like to request everyone to please assemble inside the hall. We are going to start the medical debate, the much awaited medical debate. For the debate, it's my honor to call upon the stage the speakers for today's debate, Professor Sangeetanjan Datta and Professor M.K. Goswami sir, to kindly take the place on stage. For further conduction, I would like to hand over now to the speakers.
So a warm good afternoon to all the assembled delegates here on the third and panel debate day of APICON. So we have come to an important and interesting part of the today morning session. It is a debate. It is a medical debate. So this medical debate, the topic of is general physicians are more important than super specialty experts in present health scenario in Assam. So it is a burning topic. All of us face this situation or scenario. So here we have two debaters par excellence. So one is none other than Professor Miganko Kumar Borwa. He is against, Soliha. So again I repeat, Professor Miganko Kumar Soliha, he will be opposing the motion. And for the motion, it is none other than Dr. S.M. Borwa. So I would like to hand over the mic to my co-speaker.
Go ahead. Yes. Good morning to everybody. First, we'd like to invite for the motion, Dr. Assam, is it? For the motion, they have change of this thing, no?
Yeah. For the motion, yeah. Dr. Assam.
For the motion. Yeah. The for the motion, Assam. Kiman time? What time are you giving? 10 minutes. 10 minutes. Please take over the mic. 10 minutes.
Honorable Speaker, sir, and the House. Today I am standing in front of you to propose a very important bill in the House, which is related to the healthcare system of Assam. That is, general physicians are more important than super specialty experts in the present scenario of Assam. Before going to the debate, Speaker, sir, I'd like to define the two words, who is general physician and who is super specialist. By the word general physician, I am referring to the doctors having MD degree in medicine, and by the word super specialist, I am referring to that group of doctors who are having DM degree in the different specialties. Now coming to the another word in the topic, that is the healthcare scenario of Assam. The healthcare scenario of Assam, we can divide into public sector and private sector. And according to the care, we can divide as a primary care, secondary care, and tertiary care center. Now, if we see the pyramid of the healthcare system of Assam, that the base of the pyramid is formed by the MBBS doctor. There are approximately 30,000 in the state. They are serving in the different rural areas of the state, and they are the first line of defense in the society. Then MD medicine doctor number is about 800. I have collected the data from the API directory that they are mainly working in the urban and suburban area and also in the tertiary care centers of the state. And DM doctor number is approximately 100. They are mainly city-centric. They are mainly concentrated in the city of Guwahati and also in some other main cities of the state. If we increase, if we give more importance to that group of super specialty doctor, then what will happen? We'll increase the more doctor in the Guwahati and other town area only. But India lives in village. Assam lives in village. We need more doctor in that group, general physician, general practitioner and general physician group of doctor to give real service to the poor people of the society. Sir, the word importance is a relative one. Day before yesterday, I was traveling from Dekargaon to Tezpur. During my travel, for me, that most important person was my driver. Same way, when a patient suffers from acute coronary syndrome, for him, the most important person is the cardiologist. But a patient who is suffering from lower respiratory tract infection, for him, the most important person is a general physician. But fortunately or unfortunately, we are having that group of patients. Number is, they are having the larger number, they are having the lion's share, whose diseases can be tackled by the general physician, not by the super specialist. So definitely, general physician will get more importance in the society than the super specialist. But who will guide the common people? That who is the most important person and in a particular situation. Is it Google? Is it super specialist? No. He should be the general physician. Most important person to set the importance. I think the patient should come to the general physician first. He will decide whether this patient should be treated by himself or he should be referred to a super specialist. If this does not happen, then what will happen? Coming to the three-case scenario. Number one, he is the Mr. X. He was a very smart person, had pain in his right knee. Then He searched in a Google and went to the knee joint specialist. It is a super specialty of orthopedics. The knee joint specialist examined his knee joint thoroughly, did MRI of the knee joint. Knee joint was absolutely normal. He referred the patient to physiotherapist for physiotherapy. Then his pain was increasing day by day, and he repeatedly went back to the knee joint specialist. Ultimately, he annoyed. He referred the patient to psychiatrist. And what psychiatrist did? Psychiatrist, everyone is a psychiatric patient, including himself. He treated him with an antipsychotic medication. The patient's condition was not improving. Then he sent the patient to psychologist, received psychotherapy. Condition was deteriorating day by day. Ultimately, out of frustration, Mr. X went to the general physician. General physician thoroughly examined him and found that he was having tuberculosis in the hip joint, for which there was referred pain in the knee joint. Then he diagnosed the case. He sent back the patient to the hip joint specialist for treatment. Hip joint specialist, already by this time, hip joint has been destroyed a lot, and he started anti-tubercular therapy. Mr. X then went back to the knee joint specialist and scolded him like anything, that you have spoiled my life, you have killed my lot of money and time. I was having tuberculosis in the hip joint, you could not diagnose it. Then the knee joint specialist came to know that above the knee joint, there is a joint called hip joint. Then this is a story of Mr. Y. A few days back, when I was taking around in my ward with my postgraduate students told me, sir, this is a patient with refractory epilepsy. This patient has been treated by 2 neurologists. Now patient is getting in that 3 anti-epileptic medication, but seizure is not controlled, MRI is normal, EEG is normal. We have kept the patient for evaluation. I just touched the patient, found he is having bradycardia. I told my PG that you immediately do one ECG. ECG was done. It was a case of complete heart block or repeated stroke aromatic. This is Mr. Z. Few years back, this patient came to me with breathlessness. This patient was treated by one cardiologist friend, because of breathlessness. This cardiologist did ECG. ECG was showing sinus tachycardia. He was treated with propranolol, but his condition was deteriorating, and I found that it was a case of massive pleural effusion. These are the problem with super specialists, the tubular vision of super specialist. The patient does not come to the doctor with a single organ. The patient come to the doctor with all the organs of the body. So if we give more importance to the super specialist, that will be the problem. Then another important thing is the cost. Cost is the main drawback in our healthcare scenario. An average rural Indian spend 300 rupees per month in healthcare. Assam, 32.0% population lives below the poverty line. It is not possible for this large group of patients to afford the super specialty care, which is very costly, including their consultation fees. The importance of the doctor is determined the prevalence of a particular disease. I have not told that super specialists are not important. They are important in some situation. Here, for example, India annually 20,000 permanent pacemakers are implanted. 60,000 CABG done annually in India. Here the importance of cardiologists lie. But 24% population are having hypertension without CAD. Do we need cardiologists to treat that 24% uncomplicated hypertensive patient? General physician is sufficient enough to treat that group of patients. So definitely, if we go to the prevalence of the diseases, the general physicians are more important than the super specialties in the healthcare scenario of Assam as well as in India. Sir, super specialists cannot do anything unless there is a sophisticated infrastructure. I will tell a story. If I tell the story in Assamese, you will get it more interesting. Then, এখন সার্কাস চলি আছে, সার্কাছত ঢুলুকিটো বজাইছে, বজালে এটা মানুহে বল লৈ পেলাই জঁপিয়ায়, খুব ওপৰলৈকে জঁপিয়ায়। যিমানে জোৰকে ঢুলুকি বজায় সি সিমানে ওপৰলৈকে জঁপিয়ায়। সাৰ্কাছত এটা চোৰে সাৰ্কাছখন চাই আছে, সি দেখিলে এইটোতো বহুত এক্সপাৰ্ট হয়, ই জঁপিয়াত ছুপাৰ স্পেচিয়েলিষ্ট। ইয়াক যদি মই লৈ যাওঁ, তেতিয়াহ'লে মোৰ কাম কৰিবলৈ ইজি হ'ব, ঘৰৰ গেট জঁপিয়াই গেটখন খুলি দিব, মই গাড়ীখন চুৰ কৰি লৈ আহিব পাৰিম। তাৰপিছত হেৰিয়া ওচৰলৈ গ'ল, চাৰ্কাছৰ মালিকৰ ওচৰলৈ গ'ল, যে তোৰ জুমুৰাটো মোক দে। মালিকে ক'লে কেলৈ দিম, ইয়াৰ ওপৰত মোৰ ফেমিলি চলি আছে। বোলে ঠিক আছে, তই মাহত কিমান টকা পাৱ? বোলে মাহত মই ইয়াৰ পৰা 10,000 টকা পাওঁ ঠিক আছে মই তোক 20,000 দিম ইয়াক মোক দি দে শেহত চাৰ্কাছৰ মালিকে তাক দি দিলে মাহত 20,000 টকা দিব সি ৰাতি লৈ গ'ল মানুহ ঘৰলে তই গেটখন জপিয়া সি নজপিয়াই তাক কৈছে তই জপিয়া সি নজপিয়াই তোক কৈছে আৰে তোক মই মাহত 20,000 টকা দি লৈ আহিছোঁ তই জপিয়া সি কৈছে তই ক'লেই জপিয়াম নেকি মই তোক ঢোলকিটো বজাব লাগিব এতিয়া কথা হ'ল the super specialist cannot do anything unless there is the infrastructure. So, Speaker sir, that so the need of this hour is to produce, not to produce the super specialty expert, rather to develop infrastructure. If good infrastructure is there, and general physician can perform so-called super specialty. How many district hospitals are having advanced critical care set up in Assam? How many district hospitals can do temporary pacemaker implantation in Assam? That is the need of the hour. If we develop that infrastructure in the each and every hospital of the Assam, that many things that general physician can do what so-called super specialists are doing. So my humble request to House, my humble request to respected speakers are that kindly approve that today's bill in the sake of APICON in future. Because, sir, if everybody here go for do DM degree, then who will organize APICON for home in near future? That will be a sweet memory for us. Thank you, sir.
I'd like to invite Professor Bigankos Soli.
Respected speakers, sirs, and the august audience, a motion has been tabled here that states that general physicians are more important than super specialty experts in present health scenario of Assam, and already many arguments have been given to justify the superiority of general physician over super specialist. By tabling a bill like this, the honorable member of the Treasury Bench is only asking a question. The question is, if we are to design a perfect medical and healthcare system in Assam, would you give more importance to doctors who have highly specialized skills, who are brilliant at doing a small number of things extremely well, that means a super specialist, or to people who can do a wider range of things less effectively? Honorable member of the Treasury Bench has spoken about doing certain things belonging to super specialty in presence of adequate infrastructure. That is not a way that will decrease the standard of medical care. I do not think that some of the interventions which are life-saving can be given to the general physicians in the presence of infrastructure. Actually, the thinking behind asking such a question itself is wrong. The putting such a bill itself is wrong. Because if somebody wants to say that one particular type of doctor is more important than another, I will describe that as an example of oversimplification. The bill is oversimplification because the dynamics of medical and healthcare is not that simple. A health system, it's a common sense that it requires both types of doctors, general physicians and super specialists, to deliver high quality care within the constraints of the available resources. The goal should not be to create a division, a compartmentalized division between a super specialist and a general physician. The goal should not be to establish a differential hierarchy between the general physicians and the super specialists. The goal should be to create the right balance between the general physicians and the super specialists. To create that right balance, we cannot tilt towards a particular type of doctor like the general physicians, as has been done by introducing the bill today, and because that is not going to solve the problem. To create the, we cannot, I'm not telling that super specialists are more important than general physicians, but I cannot accept a motion which says that one type of doctors is more important than the other type. That is basically unjustified. I remember a story I read in my kindergarten school days between involving a contest between the sun and the wind, both claiming the superiority over the other. As we all know that the tree asked them to remove a clock worn by a man traveling on the road, and the sun could prove his superiority. But the tree, while declaring sun to be owner, he also cautioned sun that though he owned that particular contest, had the contest been different, the wind also could have owned. And similarly, the importance of a particular type of doctor relative to another type depends on the context of the medical condition of the patient. One just cannot categorically say that general physicians are more important than super specialty experts. We cannot make a blanket statement like this. There are times and situations when a patient needs experts hands by super specialties. We know that a nephrologist can take care of a CKD patient better. A cardiologist will be doing a PCI more successfully. I do not think how if a cath lab is given and infrastructure is given, then the general physician will be doing the things needed to be done by the super specialist. How will a general physician do a primary PCI? I do not know. It is also known that a gastroenterologist will be managing a variceal bleed better. However, I never deny that there is a need of the general physicians as a linking equilibrium in a patient with multiple morbidities involving different systems. A general physician is important in his own way without undermining the importance of the super specialist. Both have their must-deserve specific sectors to perform, specific areas to walk, specific corridors to move, neither of them being more important than the other. So I come to the most important phrase in the motion, that is present health scenario of Assam. Is Assam different? How is the present health scenario of Assam different from other states of India or rest of the world to make a case for greater importance to general physician? Although the member of the Treasury Bench has shown a picture of Assam justifying